PSGs. So I have endoscopy that I'm doing under sedation, and I'm also doing a PSG on table, which tells me at what level of sleep, because this was the major objection that the non-ENT group had to us when we were talking to them about surgery, and they said, oh, you can't really find out the level. So I started doing this. And then we started classifying dyes. It became a little better. It's no longer just classified as two analysis, but it's classified with the third type also, where we talk about AP and lateral. And we're trying to get it to be very standardized, where we talk about like the TNM classification. So if I'm sitting in any corner of the world, or my colleague is sitting in any corner of the world, when we talk to them with saying V1 AP O2L T0 OE0, he knows exactly what I've looked at into the dice and what I've tried to find out. So that's a velum anteroposterior partial collapse, that's an oropharyngeal lateral collapse complete, that's 2, and tongue 0 in epiglottis 0. So that gives us a very much better classification of the dice now. The imaging part, we had 3 parts. We have the cine MRI, which I've been tom-tomming across the country since quite a few years. There is now CBCT, which I've begun to start doing. And the CBCT, if you can see here, definitely also has now landed up with the volumetric evaluation and not just simply just the cephalometric part. The cephalometry nowadays can still be used, although it has very limited role generally. But when you're dealing with a bony cage abnormality, then it is this very cephalometry which can tell you the distances of the bones, which can tell you the angles sometimes that you need, and the thickness of the bones that you're dealing with. The cine MRI, like I said, gives you a very, very clear-cut vertical as well as a horizontal AP mediolateral obstruction levels, which are at different levels, and also the fact that you can actually note and measure the distances and keep them documented for pre and post-op evaluations at a later date. So this is where the problems can come in. Cephalometry, like I said, we restricted to bony cage. The cine MRI, although it's a little difficult to sleep in that and you don't know the stage of sleep, you can use it in conjunction with the scopies and you can have the measurements from it, because logistically speaking, it is quite impossible to do a cine MRI with an in situ polysomnography together. It's logically not possible. So, and in fact, none of the investigations are really to that effect where we'll be able to give you the complete picture. So we have reached an evaluation consensus where we talk about recommended and we talk about mandatory. We say that the level 1 PSG, if possible, has to be very, very important. We talk about at least doing a level 3 minimum before you actually get into doing any kind of work for OSA. We talk about doing either a DICE for those who want to do a DICE, or at least do an awake FNLP with a dynamic MRI before you actually TEN. So this consensus is quite clear, has been published, should not have any kind of controversies with that at all. The important other questions that are generally asked out of a lot of workshops that we've conducted are related to palate, and I'm going to come to that in a bit. But the controversy is whether to try and do nose, nasopharynx, and palate. So a lot of us today, when we do our nasal surgeries, do not do packing. A lot of us have started using splints, have started using quilting sutures. But even for those who are not doing it, even if you do a nasal surgery with a palate and you're able to pass a nasopharyngeal airway, you can still pack the nose with Avalon on both sides, keeping the nasopharyngeal tube in situ. And this can make the patient extremely comfortable post-operatively. So you'll see Avalon being put on both sides. And you will see how comfortable the patient is on extubation with that nasopharyngeal airway in its place. So there is really no issue to doing a nose and a nasopharynx together. And when it comes to a palate with controversies with excision or reconstruction, it's obviously now the days of reconstruction. Nobody really wants to do excisional work. Things have become much, much more easier. and the selection anatomically has become very methodical. What do you do when you have a very thick and bulky palate? That's where the zeta actually comes in, because the UP3 really doesn't have that kind of orientation or the results that are there. So let me take you through what happened with the UP3. So this was what was the UP3. You excised this entire thing and kept it, and you realized that over a period of time it wasn't giving the required results. And then we started doing something different. We realized that it was the palatopharyngeus, which was possibly the one that was responsible for the lateral pharyngeal wall. So you pulled up the palatopharyngeus and got it onto and sutured it onto the soft palate here. That was the relocation part. Then we realized that probably that was not enough. I beg your pardon. So we thought that, okay, let's pick it up from the palatopharyngeus and bring it and hook it onto the pterygoid hamillus, which is a stronger structure, and we'll be able to get much more expansion. Now, again, over a period of time, realized that, okay, this is not working that well, and then thought that, okay, let's bring the palatopharyngeus and hook it onto the entire pterygomandibular raphe, which is the lateralmost structure and a pretty solid structure. So if we are able to do that, and this was very highly popularized by Professor Vicini, and everybody right now is mostly into this. The logic behind that being very simple, that you have the muscle that gets taken onto a very rigid structure on the lateralmost part and the entire muscle. Now, this is important to understand when I say this, that this is the entire muscle here that has to be picked up, and the entire muscle is taken in a vertical direction onto the pterygomandibular raphe. There are a lot of people, a lot of variants that were coming up, or people do, where they cut the palatopharyngeus here horizontally, and then they pull that up and take that upper part, or rather the cranial part of the palatopharyngeus, and hook it onto the pterygomandibular raphe or the pterygoid hamillus. Now, here is what we need to understand, that if you take only the upper 1/3 or upper half of the palatopharyngeus, you are not addressing the lower lateral walls of the pharynx. The lower lateral collapse is not being addressed with that kind of a procedure. So if at all you need to do some lateral wall expansion, you need to make sure that it's the entire palatopharyngeus that's coming onto the pterygomandibular raphe. And the selection now has become extremely methodical. Nobody speaks about, in my experience, or this is how it works and this is how I do it. But you have to go with an algorithm. Everything is getting evidence-based. This is an algorithm that I have proposed, which is for much more detailed explanations later on. But it tells you clearly that if you have a vertical palate with an AP collapse, you can just go ahead with a somnoplasty. You have an oblique palate with an AP collapse, you can do an anterior palatoplasty. But the major issues are when you have a lateral wall collapse. And that's where the thickness or the muscle of the palatopharyngeus comes into the picture. Because if you have it thin, you are not going to be able to pull it all the way till too far in the thickness. But if you have a thick one, you can get it and hook it onto the pterygomandibular raphe. But otherwise, you're going to have to use the relocation of the barbed if you have a thin muscle. And like I said, if you have a very thick palate, then zeta is the way to go. There is an issue with the upper and the lower tongue base. Unfortunately, there is no anatomical line that delineates the upper and the lower tongue base. But if you look at the lower end of your mentis or the mandible, and a straight line from there to the posterior pharyngeal wall, on that level is where we kind of visually, not anatomically, but visually delineate the upper tongue base and the lower tongue base. So if you have an upper tongue base, it is logical to think that you will have to go intraorally and access it. And if you have a lower tongue base, it stands to logic that you might as well do something on the external part over here, like a hyoid suspension, and then you are able to pull that tongue base anteriorly. So there is really not that much to think about. It's a visual evaluation over here, and it's the access that is available on the upper part and on the lower part. So that's where the controversies come to rest, but the decision also is a lot based on the patient profile, the other comorbidities that he has, the informed consent, and the way you explain and talk about the results that you're likely to get with one procedure on the tongue and the backup facility that you have along with your training skills and whatever else you have. Now, a very, very important topic here, which I don't put up too many slides on, but I talk on, is the fact that the PAP therapy, though gold standard by the physicians, and this is in literature, but their own literature gives you a PAP failure rate of 50%. Yes, you heard me right, in the range of 45 to 55%. And this comes in two forms. There is an initial lack of uptake of the CPAP machines, and there is a long-term compliance rate that decreases over a period of time. So both ways, their rates that they have quoted in literature are in the range of 45 to 50%. And that is in fact the same figure that has been thrown upon us as surgeons to say that your surgeries over a couple of years tend to fail, because obviously we as surgeons understand that whatever you do to the muscle, it is going to lose its tonicity over a period of time because you have moved it from its origin and insertion. And at the same time, because with aging time, you are going to lose that tonicity. So if you have comparable rates of failure with the PAP and failure of surgery over a period of time, doesn't it stand to reason that if I can do a simple oropharyngeal surgery, and when I use the word simple, I mean simple, because even a freshly passed out candidate or a first year resident is able to do oropharyngeal surgeries very easily. And if by doing that oropharyngeal surgery, if you are able to give the patient, let's say, a CPAP free period of 5 years or 6 years, then you have done justice with that simple surgery that you have done. It's like otherwise saying to people that if I do a stapes surgery, my patient is never going to get an SN loss. We all are aware that 7 years, 10 years down the line, there is going to be some SN component that will come in and the patient will require a hearing aid then. But at the same time, you've managed to give that patient a 10-year hearing aid free period. And if you can do that as simply as not even that skillful surgery as a stapes requires a lot of skill. Maybe an oropharyngeal surgery is not that skillful, but if you can get away with that, then why not? So this is the reasoning that you need to understand for the 90% of the surgeons doing 90% of the work across 90% of the country who are still probably not convinced about the fact that OSA surgeries can do wonders to the patient's quality of life. The other issue that you need to deal with is single stage multi-level surgery versus a single level multi-stage surgery. So I am a very strong proponent of single level multi-stage surgery, and there is merit in waiting always, because over a period of time when you stage your surgeries, there is a very, very good chance that you will probably have to do less over a period of time, and you have a long-term follow-up of that patient also. Whereas with the changing times and with the medical tourism that has come in, and there are people who travel to you from across cities nowadays, that those kind of patients, sometimes it is always more prudent to try and see if you can achieve something in a single stage multi-level surgery. But having said that, that has to come with a very, very proper understanding of the pathophysiology and safety measures when you're doing airway surgeries. A single level multi-stage surgery always helps us in having a very, very good long-term follow-up and keeping that patient. You will realize that it does give them better results rather than just a single stage staged event. Now, we all are doing surgeries with coblation now. So adenoidectomy is not such a big deal. There are people across the country now who are doing adenoid surgeries in 1-year-old kids, 1.5-year-old kids also. My lowest has probably been just a 2.5 or 2 year, 7-month child, but I know of so many people who are doing it under 2 years also. But the question here that you have to answer to yourself is, do you really operate on a non-comorbid child, although you have proven him to be on large adenoids, either on an X-ray or on a scopy? And the answer to that is a very, very simple yes, because if you can manage to do that, and if the patient has a pediatric OSA and not just allergic issues, then you are able to reverse a lot of these neurocognitive outcomes, as has been proven with a lot of meta-analysis and systemic reviews. And they have come to a kind of a borderline conclusion that the average age should be somewhere in the range of 6 to 7 plus or minus 1 year here and there. So it makes sense with the present tools to be able to operate early in a pediatric OSA patient. I use the words very specifically, pediatric OSA patients. Now, the barb suture pharyngoplasty is the big fad that has happened, and it's very easy for everybody to do for the shortage of time that was allotted, and we have other stalwarts also along the way. I'm just going to tell you that there is a relatively small sample size as yet also. And that's because everybody tries to do things differently. And as a result, we don't get one surgery in huge numbers. And that's what I've been trying to request people to do, that such simple surgeries can be done at different centers in huge numbers together. And then we are able, India is a country where you can get out literature and data way better than any of the other countries in the world. But we need a standard SOP or a standard operating protocol to decide on the kind of surgeries that will give the results. So this is a very simple surgery to do. I'm not going to get into too much details. You can see the pickup of the palatopharyngeus muscle that will be used with a barbed wire and attached onto the pterygomandibular raphe. The external approaches of the tongue base are restricted mainly to the bony cage abnormalities. You need to understand that there's lots that can happen over there. There's a lot of maxillofacial people and the orofacial people who are coming into this field. And that's where we have a little backseat, but we can coordinate with them and get them done. Never miss out on the epiglottis. Epiglottis becomes very important. Epiglottopexy is a technically difficult surgery as compared to the rest of the oropharyngeal surgeries. But yes, there are ways where you can do a kind of a bulgarization of the epiglottis onto the base of the tongue, or you can actually try to suture it to the base of the tongue. But yes, technically difficult, the suturing part. As a different case, I won't get into that. I would like to come to the choice of procedures being very importantly, as a lot of us, you may have heard on the dioceses across the country, when we speak of any procedure, we always talk about the patient, in inverted commas, earning your surgery. You do not go on to patient demand, and you do not subject yourself to patient pressure. So the patient somewhere along the way has to earn their surgery, and that will only come if you find out whether they are motivated enough, even though they are educated. If they are motivated enough to lose a couple of kilos in a slightly higher BMI, then you know this patient is going to do well, and these are good patients for you to be touching. Socioeconomic status, obviously not from the point of view of the money, but because of where they come from, because the rural parts of India will never really come forward with this kind of complaints to you. And follow-up issues, obviously, because if they are from out of town and you have less follow-up, then your choice of procedure may rather tilt towards a single stage multi-level procedure. Of course, based on where you find the collapse and where you find the level of obstruction, that's how you decide. And not only just the patient factors, but also the surgeon factor, where your intricate knowledge of the pathophysiology and your training becomes extremely important. Equipment is not that really necessary, because a lot of things can be done without sophisticated equipment, but you need to have very good backup facilities. And at the same time, you need to understand it's that the patient has to be willing to take the risk, not you. And the trends are definitely changing over the world, where you are moving from the invasive to the non-invasive work. About 2007, when I first gave my talk on OSA somewhere in the country, it was Aurangabad, then Nasik, and then Kolhapur, and then Chennai. So hypoglossal stimulator was the last slide which I used to keep as future in India. And I used to say, this is the next big thing that is happening. 14, 15 years down the line, this still remains my last slide, because they have really not moved forward across the world for reasons of cost, for reasons of FDA, for whatever you may call it. And I really don't think that they're going to come back into the country or come back into the field so early. But yes, for completing a kind of a OSA situation, hypoglossal stimulators become very important. We need to do a lot of research on the different type of procedure and results, where we have also been trying to give out fellowships and training programs and talk to the legislative authorities, mainly to get it sanctioned by the insurance companies. So, ladies and gentlemen, and all my friends, here's a few take-home messages where just the AHI normalization is not our goal. That's not what we are looking at when we're doing AHI surgeries. So be convinced that OSA surgeries do well. Don't go by maybe a physician's criteria to tell you that an AHI has not come under control and so your surgery has been a failure. At the same time, your endpoint should not be the AHI, but a safe and happy patient, safe being more important, happy, of course, and the bed partner, and you have to have a long-term approach. And even a partial improvement in bringing down the, bettering the quality of life of the patient can make so much of a difference. But here's a little parting thought for food of thought. So when I'm doing this, when I'm doing a DICE, what am I really doing this for? When I gave it a lot of thought, did the PSG really make a difference to my thought process in changing my treatment protocol? The answer that I got was a no, a clear-cut no. So maybe I realized that all I was doing this for was to go better up on a chest physician or a non-ENT dais and say to them, okay, listen, that was your objection to me doing a DICE, and here I'm getting rid of the obstruction. But frankly speaking, let me tell you, I don't think this is needed at all. And in fact, coming to that DICE part of it, which I was trying to tell you, there is something that I keep telling everybody, that if you have a lateral collapse on a flexible awake scopy, and maybe it's 20-30%, we are all very clearly aware that this collapse is going to get worse when you do DICE. You will see a definitely more, a worse collapse when the patient is asleep and under anesthesia. But does that change my decision making? When I have seen it in the awake scopy, am I not going to be addressing that? Or is there some criteria that tells me that, okay, 20% lateral collapse is not to be touched, but if it is more than 40% lateral collapse, then it has to be touched. So when I'm going to see a 20 to 30% also lateral wall collapse in an awake situation, and I am going to touch that, then why am I insisting so much on a DICE? Which obviously, yes, it will give us a different picture slightly, but does it really make that much of a difference to my decision making? So does that playing around with the palatopharyngeus, is that the only thing that makes a difference to the long-term outcomes? No. This is what people have to understand, that it's not just that oropharyngeal little surgeries that play around with the palatopharyngeus, but we have to be on the same page and evaluating the patient thoroughly and coming on the same page for operating protocols, because whatever we do have limitations to understand that this is the part where an ENT surgeon comes in, not any of these parts. But if the ENT surgeon does not understand any of these parts, you're probably going to fail in even the best of the things that you do in this part. So this role of the sleep apnea surgeon is extremely important. And if you realize that understanding the pathophysiology of OSLA, does that translate into better surgical results? Most definitely, yes. I can put this down with conviction that it definitely does, because that's how you're able to give the better results to the patient. So thank you everyone for a patient listening. I would be open to any questions across the way before the other surgeries start. I always part with saying that the more you know, you realize how much you don't know, but the less you know, you really talk a lot more. So maybe I was harping a lot more 15 years back, as much as I don't do now, because now we tend to know a little bit more about the pathophysiology. So thank you very much for that patient listening. And I'm sure you all enjoyed it along the way. Yes, sir.
Yeah, we are also very happy that we want our patients to be safe first.
Sir, absolutely. In fact, I was wanting to try and get into the post-op extubation of your patient, but for want of time, I didn't intervene, and I said, let's not get there. That would have been very wonderful to be extubated and shown.
No, honestly, what happened was because of too many centers being connected,
absolutely, sir.
I couldn't hear your questions properly. The audio today was a little bit, probably because too many centers being connected. Half the questions I couldn't hear.
No,
it's not that I didn't want to answer, but the audio ones wo nahi sunai deta to thoda
Bilkul, sir, and as being organizers with all of you, we understand constraints, so we don't want to
Yeah.
unnecessarily.
42 centers across India to be connected by this land.
Huge, sir.
And technically, even with the best efforts, Alembic also. Sometimes, these are technical. So, but it's a pleasure, Seema.
Thank you, sir.
Always to listen to you because you balance both well.
Thank you, sir.
Not the cavalier, we'll operate for everything types. So I've always liked you, your presentations, your humility, the way you present. Thank you very much, Chief.
Thank you very much, sir. Thank you. Thank you for having me here, sir.
Thank you so much, Dr. Simab Sheikh. It was a very informative and valuable session. Let me again call Mr. Dr. Dinesh Patil to introduce our next esteemed speaker for the day.
Thank you, Diti. The next surgeon in line with us is Dr. T.N. Jankiram. He is a world-renowned rhinologist, skull-based surgeon, started his center, Royal Pearl Hospital, 23 years back. He has traveled across the globe to demonstrate live skull-based surgery. He is the most wanted, demonstrated in many countries. He has given oration in USA, Germany, Brazil, Korea, Taiwan, and Japan. He has many accolades to his credit, like he was awarded Best ENT Surgeon in Tamil Nadu 2008 by Chief Minister, Young Indian Scientist again in 2008, Best Doctor of the State in 2022, Best Rhinology Teacher in 2022 of Heinz Stemberger. His latest development was started a new venture across Hyderabad. He will be operating in both the states, and he is the director of Roy Group of Hospitals. Sir, today we are going to perform a surgery of pituitary tumor engulfing ICA. Over to you, sir.
Hello.
Yes.
Can you hear me?
Yes, sir. We are here.
Okay. I first of all thank Alembic Pharmaceuticals for this mega venture, and I have been enjoying Masterclass since its inception, and now it is Masterclass Prime, means many steps ahead, and we are now operating from our own centers, which makes life very easy, less travel for us, but at the same time, reaching out to many more doctors than we used to reach. So I should thank COVID for that. COVID has helped us in many ways. So I next thank the organizer of this prestigious conference, Dr. Deepak Haldipur, who I call the K. Balachandar of ENT. You saw him doing a fantastic case in the morning. And also I thank my teacher, Dr. H. Vijayendra sir, who taught me the basics and concepts in otology. I have a special thanks to Mr. Rajit, who is my very close friend from Alembic. And I really thank you for all your efforts you put in to assemble doctors in 42 different centers. And I think more than 4,000 doctors would be watching this program. Okay, now let us, without much ado, go to the case. My resident, Dr. Sangeeta, she is from Jipmar, Pondicherry, and she will be highlighting the case, and then we will take over from there.
Thank you, sir. Okay. Good afternoon to you all. I'm Dr. Sangeeta, resident at. Okay. So it's okay. So I'm Dr. Sangeeta, resident at Royal Pearl Hospital, Trichy. So on behalf of Royal Pearl Group of hospitals, I welcome you. That is Royal Pearl Hospital, Trichy, Century Royal Pearl Hospital, Banjara Hills, Hyderabad, Olive Royal Pearl Hospitals, Medipatnam, Hyderabad. So I welcome you all. So our first case is a growth hormone secreting pituitary macroadenoma. So our patient, he is a 75-year-old male. His main complaints were progressive blurring of vision in the left eye for the past 4 months. Also, patient has noticed some differences in his facial features. Apart from this, there was no history of any other endocrine disturbances. There was no history suggestive of raised ICT, like headache or vomiting. He's a non-diabetic and a non-hypertensive. So next, going on to examination, the patient had prominent frontal bossing. He had a prominent supraorbital ridge. His tongue was thick and macroglossia, and he had typical spade-like hands and thick lips. So apart from this, the rest of the ENT examination was normal. Now, ocular examination showed in the right eye, there was mild disc pallor. In the left eye, there was temporal pallor. The right eye visual field, there were scattered field effects, and in the left eye, there were complete field effects in all the quadrants. Also, the color vision was defective in the left eye. The extraocular movements were normal in both the eyes. The colonoscopy of the patient was normal, and his echocardiogram was normal. So here you can see the thickening of the fingers and typical spade-like hands. So going on to the hormonal profile of this patient, his hormones, most of the hormones, the cortisol, free T4, FSH, LH, they all were decreased. Prolactin levels were normal, but mainly growth hormone and IGF-1 were raised. Now, growth hormone was not suppressed even after an oral glucose load. That is, after giving 75 grams of glucose, at the end of 1 hour, growth hormone should fall to less than 1 microgram per liter. We see that here in this case, it is persistently elevated. So next, going on to the MRI findings. Now, MRI showed so MRI showed a homogeneously enhancing cellular and supracellular mass, which is widening the cellular with left paracellular extension. It was pressing on the optic chiasma, and it's completely encasing the carotid. So here our diagnosis for this patient is growth hormone secreting pituitary macroadenoma with supracellular paracellular extension, central hypothyroidism, and hypocortisolism. Okay, sir. So next, over to sir for discussion of MRI. Thank you. Nice.
It's okay. It's okay. Okay. So, hello. Did you hear the history? Who is the moderator, please, so I can talk to them?
Yes, Janki, we could see the history very
Can you
nicely.
increase the
The
volume?
slides were visible. Now we are seeing your MRI pictures
Is it Dr. Vikram Khanna, sir?
from Mumbai.
From Mumbai. Okay. So let us talk about pituitaries in general. So first of all, I want to tell you that skull-based surgery is a teamwork. So I never operate on any skull base without a neurosurgeon. So I thank our neurosurgeon, sir. Dr. Vijay Kumar, sir, he is sitting there. Dr. Vijay Kumar, sir, he is in charge of Neuro One, a very, very leading center in Trichy. And he is there with us. So I always believe that we should do skull-based surgery along with a neurosurgeon. Point number one. Point number two is coming to pituitary macroadenomas. As we know, there are two kinds. One is macroadenoma, second is microadenoma. Macroadenoma greater than 1 centimeter, microadenoma less than 1 centimeter. Now, the commonest pituitary tumor is prolactinoma. So that is the commonest pituitary tumor. And most of the prolactinomas are treated medically. They are not treated surgically. Most of them are treated medically. Only if it causes optic nerve compression or apoplexy, then you go in for surgery. So medically, we give cabergoline, which is a dopamine receptor agonist. And so cabergoline tablets are given twice a week, and that takes care of the prolactinoma. The second important common tumor is incidentaloma. Means a patient presents with headache and bitemporal hemianopia, and that is how they present. And that is, again, when there is a compression on the optics, then we generally go in for surgery. Now, among the secretory macroadenomas, first is prolactinoma, second is growth hormone secreting tumors, and they are acromegalies. Now, how do these patients present to us? If it is before puberty, then you'll have gigantism, but after puberty, you'll have acromegaly. And when you look at it, acromegaly, what happens is there is increased growth hormone secretion. So growth hormone is the central hormone, and the peripheral hormone which acts is the insulin-like growth factor 1, IGF-1. IGF-1 acts on chondrocytes, osteocytes, and all the bone and cartilage forming structures. So when you look at the face, you can typically see a frontal bossing. Number 2, you'll see prominent supraorbital ridges. You will see a hypertrophied pinna, a fleshy nose, a thick lip, macroglossia, and you can see the typical feature of a acromegalic patient. But for it to develop, it takes 10 years for this. That means by the time the features start appearing in the face, already the tumor has taken 10 years to grow. So this is the usual duration of growth of this tumor. Now, this also affects the bone, like it causes osteoporosis. And it is actually another important thing about it, it causes metabolic disturbances. So metabolic disturbances, it can cause diabetes. So, and cardiac problems. It can cause a lot of cardiac problems because it acts on the lipid metabolism. Growth hormone also acts on the lipid metabolism. So you'll have cardiac problems in 30% of acromegalic cases. So this is about metabolic. About respiratory, if you look at the nose, as I told, in the nose, the bones will be very thick. Septum will be very thick and deviated and things like that. You might have snoring. Patients can present, like Dr. Seema Abhishek was talking, it can produce snoring, and patients will produce come with just snoring, and he might have acromegaly. And the problem will come when you intubate, extubate, because thickening of cartilage is the larynx. So the anesthetist should execute extra precaution while we are operating on acromegalic patients. Now, this is about the larynx, respiratory thing. It can also produce hypertrophy of the colonic mucosa. So it can produce colonic polyps. That's why any case of acromegaly, we always do a colonoscopy to check if there are colonic polyps. The patient can present just with melena. Well, if you look at it, some patients, lady patients, present with menstrual disturbances. How do they present with menstrual disturbances? Having an acromegaly, because the same cells also are involved in secreting prolactin. So what happens is, when you look at these patients, the prolactin level will be increased. And if the prolactin level is increased, some people might think it is prolactinoma. No, you have to do it in dilution, and you will find that the growth hormone is increased. So what do you do after that? Once you have made out, maybe it's a case of a secretory macroadenoma, what do you do? Number 1 is we do what is called the growth hormone assessment. Growth hormone assessment cannot be done because it varies with time period in the day itself. So we give a glucose challenge. So we give a 75 grams of glucose, test the growth hormone. It's called the glucose challenge test. We test the growth hormone, and you have to have a value less than 1. If it is, say, 2.5 and above, then for this patient is 5, then you can diagnose acromegaly. That is the central component. The second is the peripheral component. How do we study that? IGF. So IGF-1 assays should be done, and if it is more than 200, but it is age and gender specific. So you cannot just say some patients, children will be low. So more than 50 itself is significant. It depends upon, so you will have the titration value, and depending upon that, you should tell what is the value. So IGF-1. Okay. So after the surgery, you can monitor these patients with growth hormone, glucose challenge test, and it will reduce in 1 week. If you remove the tumor, it will reduce in 1 week. But IGF-1 will take 3 months to reduce. This is very important. It will take 3 months to reduce. Well, this patient, suppose we don't operate completely, then we give tablets. So what do we give? Octreotide. Tablet octreotide is the tablet injection. It's an injection, depot injection called octreotide. It's around 20,000 rupees. And you give once a month. Continuously you have to give. Or you can give pegvisomant, and that's also injection, but that is very expensive. It's around 1 lakh. One injection costs 1 lakh, and you have to give lifelong. Per month, you have to give 1 injection. Okay, now, if you don't remove it completely, then that is the problem. So to chase any secretory tumor. And if you are not able to, the last resort is gamma knife or radiosurgery. Now, let us go and read this scan. Can we operate on this case and clear it fully is the question now. Let us see. Now, if you look at it, this is I think the most challenging pituitary you can ever imagine in your pituitary career. So we have done more than, I don't know, 850 cases now. And out of which I think this should be one of the most difficult cases which you will be doing. And generally, I have not seen in any workshop being demonstrated this kind of case. The reason are as follows. Number one, when you look at the MRI, this is a post-contrast MRI. You can see here. This is the, can you all see the MRI, please? Who is the moderator?
Yes.
Yeah, I am the moderator, Janagiram.
May I know who is it on the other side?
Hey, Anthony.
Hey, Anto. Super, Anto. Thank you. Thank you for being there. Now, this is the post-contrast MRI. You can see that this is actually the maxillary sinus, and you can see that's the posterior ethmoid, that's the sphenoid sinus. And then when you come here, just have a look at it. So you're seeing that tumor right here inside the left sphenoid sinus. And then it's actually going, this is a carotid, clinoidal carotid. And you can see that this carotid is completely encased. Anto, can you see that?
Yeah.
And the supracapsular component is going towards the third ventricle. This is the third ventricle, this is the lateral ventricle.
Janki, can you request the cameraman to, zoom on the exact pictures that you are showing?
So,
Yeah,
good
it's
afternoon
fine.
all.
Can you zoom a bit?
One more thing, we also would be having a moderator from Bangalore as a venue. So, we have Dr. Puthu Madaiya. So, let us welcome Doctor. So, he'll be moderating the case for
Hey.
Jankiram.
He is Dr. Putta Madaiya.
Puthu Madaiya.
Small Madaiya.
Sir, good afternoon, Puttamadaya,
Madaiya
sir.
stands for a god.
Sir,
Good
good morning.
afternoon, sir.
Sorry, good afternoon, sir.
Good afternoon. Good
Sir,
afternoon,
this is
sir.
Anthony.
Good afternoon, Talaiva.
We have
Sir,
several Talivars here. Very nice. Very nice to have all the Talivars together. So please
Everybody
interrupt me and
just
ask
come
questions.
forward.
Janki, what sequence MRI do you ask for?
Okay, whenever we have a pituitary, we have 3 sequences which I always ask for. Number one, we do a routine CT just to see the pneumatization, the septal deviation and things like that. But apart from that, we ask for, number one is a T1 weighted image. That's a normal T1 weighted image where you will see normal anatomy. And what happens is that the normal gland enhances in a T1. So you can see where the normal gland is pushed. So that is why we ask for a T1. Number 2 is a T2 image. In that, we will see the pathology. In that, we can see whether there is, salt and pepper appearance. You have liquid or a solid consistency. So you can definitely, you cannot make it definitely out, but then you can at least be sure that it is definitely not very fibrous. But the most important thing is a T1 with contrast. T1 with contrast, if you have a potato-like appearance, a homogeneous potato-like enhancing mass, it is generally a fibrous tumor. Because cellularity, if you have a lot of cellularity, you will have a good enhancement and you will have uniform enhancement, and that's a dangerous thing to operate. It always becomes difficult. You have to do an extracapsular dissection. But also you can do a diffusion weighted image, D1W. In diffusion, if you have a higher diffusion, then you have more liquid. If you have lesser diffusion, you have, so it will be hypointense. So in this, I'm showing you two images. One is a sagittal cut and then a coronal cut. I usually use coronal cuts. Even with contrast, straight away will give you whatever information you're asking for. Now look at it very carefully. You can see the tumor here. That is the keel of the sphenoid. You can see the carotid right in the center. Can you all see that? Anto?
Yes, yes, yes.
Professor Anthony, I will be calling as Anto because he's my classmate. He's the encyclopedia of ENT. Whatever doubt I have, I'll ask him only. So it's like that. We are classmates. So sorry if I'm calling him Anto, even though he's a professor. So you can see that he is actually, you can see that this is a supracellular extension. This is a paracellular extension. This is a paracellular extension. And you can see the carotid is completely encased. And you have this cap-like structures going towards the third ventricle. This is going towards the bifurcation of the MCACA bifurcation. Of course, behind the carotid also you have a component which is the petrous apex component. This is the petrous apex component. And now, what is the main problem in this? Of course, we have operated on several cases with cavernous sinus, but this patient, you can see very clearly, see this like an eye. Can you all see this? You can see this area?
Yes.
Now, this is an atherosclerotic patch. And this is a fusiform. You can see this carotid angiogram compared to this carotid angiogram. Can you see that? Hello?
Yes, yes.
So this is dilated. So this is a fusiform aneurysm of the carotid.
Maybe, can it be because of the pull from the tumor?
Yeah, you can, because I told you it acts on the metabolism of the lipid, and you have definitely a problem. Or maybe the patient is also old, right? So you can have that. This patient has got a fusiform dilatation of the carotid, so I cannot manipulate too much on the carotid, number one. Number two is that you have the tumor right on either side of the carotid. And if I dislodge this plaque, the patient can land up with a stroke. So that is another important thing which I have to think about. And of course, I just want to show you some of the things. So as you know, aneurysms are of three types. One is called the berry aneurysm. Second is called the fusiform aneurysm. Third is a mycotic aneurysm. So we should be prepared for any eventuality. You can see here that these are all aneurysm. It's all sterile, right?
Lips.
Can you see here? The aneurysm clip applicator here. You can see, and the aneurysm clips are all here. And our neurosurgeon, Dr. Vijay Kumar sir, is also here with us. I'm sure that it's going to be a super interesting case. And you have any questions regarding it, of course, the neurosurgeon also can answer. The anesthetist also has a challenge. This is, I think, one of the most difficult cases shown in any conference ever so far. So that's why I thought, okay, let us show this. And more importantly, the daughter of this gentleman is a doctor. So are you getting the endoscopic picture, please, Anthony?
No, not yet. Yes, now.
Is it clear? The endoscopic picture is clear?
Yes, very clear.
Yes, it's quite clear.
So any questions? Okay, what's going to be my plan? Plan of attack. I always say in skull base, you should...
Amazing picture clarity, Janki. We are
Thank you,
getting
sir.
very good picture. Yeah.
All your blessings, sir. I'm starting. I want to cut off this slide. I want to tell you what are the steps. I always write the steps. So I can show you the steps here. Can you show me this? This is the steps chart. I always say, always plan your surgery before you start operating. I always like to write it down. Writing is better than thinking. So I'm not going to do the first step because you have a septal deviation. I'm going to start with the second step. Right partial middle turbinate resection, right posterior ethmoidectomy, and then a cavity and a half for the right side. Right side, I'm going to do a Haddad flap. That's an nasoseptal flap. And then I will, left side, I might resect the inferior turbinate and go in for an endoscopic modified Denkers because I am a little scared. If there is bleeding, then I have to control whatever bleeding is coming from the cavernous sinus or from the carotid. So I'll go in for an endoscopic modified Denkers surgery, and I will ligate the SPA DPA and go for a posterior septectomy. I'll do a triple osteotomy and then go for a transpterygoid approach locate the median nerve, the V2. I'll go for a transcellular, transplanar, transtubercular approach. And then I'll start dissecting the cellular component. Very carefully go across the carotid and then start dissecting the cavernous sinus component. And finally will be the supracellular component. So this is going to be my chart. So I'm going to follow just these steps, which you're going to see right now.
All the best.
Thank you. Thank you. Right. Now I'm going to start with the right side. Let the discussion be two-way. Anto,
Yeah, listening.
let it be two-way.
Yes, yes, yes.
And whatever questions, whatever center, I'm ready to answer. Okay, right. Let me get started. Now, I'm going to start this case with lateralization of the inferior turbinate. So you can hear that tuck even in Chennai and also in in Pune. Right. So that's the first step in pituitary surgery for me. The second step in pituitary surgery would be the resection of the middle turbinate. So you see how I'm holding my scissors? It's oblique. It's not straight. It's oblique. And then you see the first cut. It goes like this. And then you just have to press it downwards. See that? Never try to keep cutting it. It's not required.
Janaram, what's the BP now?
BP is
90/50.
90/50. Dr. Bala is here. You want to talk to him?
Yes, yes, yes. There's a wonderful anesthesia and wonderful hypotension. You can see.
So you know Bala. Bala is now famous, more famous than me.
Yeah, he gave anesthesia even when his father had a problem.
Yes, yes,
And he
yes.
didn't let you know.
He is so dedicated. Give me elevator.
So, Janki, at the end of the program, we can sing Bala, oh Bala, isn't it?
Bala, oh Bala. Wow. The Balachandar KB is telling, Bala, did you listen to that? He says, yes, he doesn't have a mic. Anyway, we'll make him talk. The problem with acromegaly is that the bones are very thick. So even lateralization becomes really thick. This is the problem with acromegaly.
Now I realize why Janki builds those biceps.
And he just-
No, it's so true, especially in acromegaly cases.
Yeah,
Cushing sits the other way, but
yeah,
acromegaly, yeah, you're absolutely right.
exactly. All the bones are so thick, sir.
Yeah,
But believe me, this masterclass concept which Dr. Haldipur sir created, unbelievable. And it is his brainchild.
no, the best part is it's a multi-starrer movie, no?
No, that is the
So-
best part. You created the whole concept, right? Like Bahubali, you created that, bringing a lot of stars. And you can only do it. See the skull base. Can you all see the skull base?
Yes,
All of
yes,
you?
Yes, yes, yes.
See the field, boss. See the field Bala sir is giving me.
That's
This is the
why
advantage of operating in your place through body.
Sir, what are the drugs used for hypotensive anesthesia, sir?
Dr. Bala has to tell that. Bala, you would like to talk? He says after the surgery, he is a little tensed about all this aneurysm stuff and all. Now he's little.
Okay.
Sir, he uses everything, sir. It's a cocktail. It's a real good cocktail. I know.
Yeah. So can you see the sphenoid os there, please, all of you? That one?
Very clear.
Inferior half of the superior turbinate is cut, right?
Yes, that's a superior turbinate. Which, oh, didn't I tell you? I'm sorry. Bala distracted me so much. Sorry. Bala, you're a source of distraction and attraction here. Okay, here we are. What I'm trying to do is now take off that inferior turbinate. Give me a pack. Now, the next step which I'm going to do is to keep a pack. See, this pack is what I was talking about. You should never leave these packs. This is the problem. You have to write down what pack you have kept, what Merocil you have kept. And this is something which we have experienced ourselves that, leave behind something and then the patient comes in the post-operative period with some packs like that. Elevator. So it's a very important carry home message, because at the end you'll be full of blood or something like that, then you will not know. See, I'm not able to enter also. It's like so tough.
Dr. Jankiram,
Yes, sir.
two questions.
The brother-
Firstly, as it is a huge tumor and
Yes.
it has approached the petrous apex, but
Yes.
the patient has no complaint anything about vertigo or deafness.
Drill mode. Yes, please carry on. Yeah. I'm going for the forward mode now.
Secondly, whether you still use for hemostasis undiluted adrenaline.
Of course, I use 1 in 1,000 adrenaline. You would have seen my several conferences. No, I want forward mode, my dear friend. Drill mode. Now you can see, I'm going for the drill mode. See that? So a surgeon should actually use drill mode whenever you want to tackle with hard bones. See what I'm trying to do now? Can you appreciate it?
Yes, yes.
Yes, sir.
So it's not the drill I'm using the debrider in the drill mode. Okay, right, change. Your two questions were, do I use 1 in 1,000 adrenaline? Yes, I use 1 in 1,000 adrenaline, and that is subject to my anesthetist. If he says, go ahead, I will use it. If he says sorry, then I will not. But my anesthetist, both in Neuro 1 as well as in Royal Pearl, both of them are so nice to me. One is Dr. Ram Gopal Gupta from PGI, Chandigarh. Fantastic anesthetist. Of course, Dr. Bala also. He makes me use that 1 in 1,000 adrenaline, unquantified, undiluted. So the controversy is, how many ampules can you use? I think that's not a correct question, because adrenaline produces vasoconstriction, prevents its own absorption. So when I use it topically, I'm not injecting. When I use it topically, now I'm using warm saline. Can you see that now, please? See, Dr. Yogendra from Rajasthan, he's our one of my best residents I've ever had. And he's actually assisting this case. And you can see that's the final end of the surgery. Now, let us go in for the Haddad flap, nasoseptal flap. So 1 in 1,000 adrenaline is what I use. The second question which you asked is, what is the next question you asked?
Yeah, actually, I wanted to know that in spite of the tumor being a huge one and approaching the petrous apex, but the patient has no complaint like vertigo or headache.
No, petrous apex, it is actually going towards the petrous apex, but the bone will be intact, and very rarely it produces sixth nerve palsy, pituitary tumors. Only cardomas produce it. So cardomas are notorious to produce sixth nerve palsy, whereas the pituitary tumors very rare. I have seen a few cases, sixth nerve palsy, third nerve palsy, but they're all very rare. It goes retrogeno. In the medial compartment also it can produce. See that? With see, what am I injecting now? It is not adrenaline. It is just saline. It's just saline. Knife. So I'm going to now start taking my nasoseptal flap. You see that? Okay, now why am I taking this nasoseptal flap? So there should be a reason for every step which I do. So the reason for taking this nasoseptal flap is, number one, it's going towards the third ventricle. Number two, suppose in case I don't, injure the wall of the ventricle, then the carotid anyway is going to be exposed. The carotid is going to be exposed, and then you have to use it on the carotid. See here, this is something very important. You see here, hey, wait, don't do it. Yogendra, please. You can see here that this side, there is a massive, can you see that, please? You see here. Now, how do you tackle this bump? Always when you do the Haddad, don't elevate here, it will tear. So what you do is you go back, and then from backwards come front. See that?
Beautiful. Fantastic, Jan.
See that? So beautifully you can see that coming out nicely. And now I have elevated it without a tear. Now knife please. Here. Now I can see here that this is the nasal flap, and I have now gone right towards the floor. Now elevator. So use a sharp elevator, my dear friends. Very, very important that you use a sharp elevator. Many people use a blunt elevator. Blunt elevators actually cause a tear in the flap. See that? Can you see the floor, please, all of you?
Yes.
Yes, sir.
KB is there. You know who is KB?
Yeah, I'm very much here, boss.
K. Balachandar of ENT. There's a very small tear, I know, but I'm just going to extend it right up. नहीं चाहिए यार क्यों यार elevator please. Last time what happened is when we took Hadarts, patient had massive cough and actually it slipped off. So Shilpi is insisting that I take a bigger Hadart. Now the problem is if I go slightly up, then you will have a problem with olfaction. See that this is a different way to take a nasal flap. Some people take it from backwards front. I take it from front backwards. That is the difference between how I take and how Professor Gustav Hadart takes it. Now you can see here, elevator. Are you all happy with the field, please?
Yes, yes.
How's the picture quality, Anto?
Very much.
Okay, scissors, please. Now, till where can you raise this Hadart flap? Actually, you can raise it till the level of the sphenopalatine artery. That's called Hadart transposition. I'll show you that. Now, give me a knife. Okay, having done that now, the next step is to make the inferior incision. Okay? Right, here we are.
You have an excellent field, Janagram.
This is courtesy, you know who. See, advantage of operating in your homepage is this. In fact, in Hyderabad now, I got a beautiful anesthetist. He's also superlative. He is like trained in PGI. Wonderful anesthetist. Very, very, very strong in his basics and gives wonderful anesthesia. I think anesthetists make a lot of difference in your life. Okay, now having done that, I'm just going to take this out. Okay, now having done that now, I am almost done with the nasal septal flap. Nasal septal flap, ideally for me, it takes around 5 to 7 minutes. If done properly, without a deviation, then I think 5 minutes is more than enough to do a nasal
in this we can say we are Janki to the power of 5. We take 30 to 35 minutes.
Sir. No, if it is not deviated, I'm telling you, if it's not deviated, simple. That's it. See, now the thing is, give a wash. Now I'm giving warm saline wash, Dr. Yogendra.
Are you planning to take a rescue flap for the patient?
Not really, because cavernous sinus. Yeah. Now scissors, please. Now I'm just going to see that how I have raised that flap there, and then I make my inferior cut. It's very difficult to make a cut with a knife. Once you elevate it, it doesn't actually, it keeps moving. You get that point, Dr. Anto?
Yes.
Okay, right. See, beautifully now gone. So in case of clival tumors, we harvest it in the middle medullary antrostomy. Now you have to see two important landmarks. One is pterygosphenoid, see that pterygosphenoid synchondrosis, and you can see a small canal here.
Median canal. So
That is the palatovaginal canal. Can you see here the palatovaginal canal, all of you?
Yes.
I can see that very clearly. See that, the pharyngeal nerve going inside.
Yes.
Very nicely seen. And then now I'm done with my, see, the bone is actually very hard. It is not the usual bone. Now, what I will do, see this side, I'll show you, it's a massive septal deviation. See that?
Hello.
Yeah.
Dr. Janki, is a question from Pune.
Yeah,
how
hello,
you,
sir.
Yeah, fine. How do you decide on which side to raise the flap, Hadad flap?
Hadad flap, generally, I raise it only on the right side, mostly. Okay. The reason is because I need more space on the right side for me to, for my 400% to enter. So generally, I raise it on the right side. But in case I'm doing a transpterygoid approach on the right side, then I will go in for a left-sided Hadad flap. Apart from that, generally, I elevate the Hadad flap only from the right side. So right side is my mantra for the Hadad. So here you see how much of septal deviation this patient has. So you don't have to go that side and do the septal correction. You can actually take it from this side and do it. Can you all appreciate that?
Yes, yes.
Scissors, please. I need a thick scissors.
Ready.
See, cartilage, there is no cartilage itself. All bone only.
Whenever you do a transpterygoid, you ligate the or cauterize the sphenopalatine artery. So you don't
Yes.
take an Hadad on that side. This is for the PGs.
Yes. Ah, okay. Right. Elevator? Yes, that's the right point. So if you take a transpterygoid approach, the first step would be the ligation of the SPA DPA. And so you're losing the vascularity of that flap. So you cannot take the flap from that side. Now what I'm going to do is to take a free flap here. I will do that. Okay. This side, this is also deviated. I think I will not touch that. Just push it. Okay, so I'm going on to this side dissection. I'm going to do an endoscopic modified Denker's in any case in this case, in the side. So I'll get space here. Okay, now let me go in for a inferior turbinate resection. No, publish.
I use the gouge to push the septum on the opposite side.
You can do that. You can do that. That's a good idea as well. Now, hey, Tanni Kuduma. Tanni yellow. See, whenever you have cavernous sinus involvement. Hello?
Yeah, listening.
Are you with me, sir?
Yes.
Anto?
Yeah. Can't you hear
Very
me?
much.
They've lost me.
No, sir.
No.
We are watching the videos. Surgical video.
अरे यार क्या हुआ?
Janagram, we are listening to you. Are you not hearing us?
But he is not listening to you, Anto.
Hello, can you hear me, please?
Yes.
Yes.
We are
Yes.
listening to you. Very much.
No, because
Me-
this here, the picture is gone.
No,
Here
no,
picture is very much there.
See this? This.
And Deepak is in
Hello?
great mood.
Hey, make that sound, man. I'm not able to hear it, man.
Sunday afternoon da varno kadiyadu thanni ginni, so I'm in good mood.
That is not our mistake, boss.
Mistake illada, blunder.
You should have your own fun, right? You can't expect everything to be provided.
Oh, even Janki surgery itself is intoxicating. Saindra paakalam.
Okay, give me. So, whenever you're doing cavernous sinus surgery, always try to give a better exposure. In fact, the neurosurgeon, if you're working with, he would love to have a better exposure. And the best exposure would be given with a limited Denkers. It's not the usual one which we do for the JNA or got it. So just do a limited Denkers. You see what I'm going to do in this case. But the exposure you will get is wonderful, wonderful. You'll see that now. So always when you have, see, we operate on tumors which are going to the temporal lobe, completely into temporal lobe. And for that, or you can do a cross-coat. But even cross-coat is not as good as an ipsilateral Denkers. Fantastic exposure. Of course, the cross-coat will give better access to the Peters apex. Now you can see here, that is the end of the pyriform aperture. Can you see that very clearly, all of you?
Yes.
Okay, right. Now,
When you do it for
I'm using
the
nonsense, my dear friend.
Janagram,
Hello?
Janagram, can you hear me?
Sir, population use panna the TV வராது.
Okay. Hello? Yeah.
Hello, Janagram, can you hear us?
Yeah, now I can hear you.
When you do the modified Denkers for cavernous sinus, what will be your lower limit of exposure of the pyriform fuzzer?
Good one. See, the 3 osteotomies have to be planned. I will not go very lateral. I'll just stay here. Drill.
At the level of the infraorbital now.
Maybe even medial to it. But main thing is superior. See, I'll go nicely superior. This is my, irrigation varlama. Inferiorly, I don't need too much. Inferiorly, I don't need too much, Anto.
Yeah, I understand.
Okay, unlike an inverted papilloma and all, where you say that we need to really go inferior, isn't it, Jan?
Yeah. Here we don't need to go inferiorly because I am not bothered about the alveolar recess.
Yeah.
So there are 2 areas where you go inferiorly. One is alveolar recess, second is parapharyngeal space. If these 2 are involved, always go inferiorly.
Even if it is a premaxillary involvement of a mucormycosis.
Yes.
Alveolar involvement.
Yes, you're right. So here we are. I'm just going to remove this part of the anterior pyriform aperture. See how limited I did that, Denkers.
கொடுமா irrigation.
This much amount of removal may not need any
Bigger section.
Drill.
reconstructing.
Suction. Illama, suction koduma. Now, the only caveat in making this is that most of the times you will think that you entered in the maxilla, and the maxilla, I've seen this very often, it would have bowed like this laterally. So you will still be in the inferior meatus. This is one caveat. You should always think about that caveat. Drill. So I hope I understand. If you have type 2 or a type 3 hypoplasia, what happens is there is bowing. Lateral bowing of the medial wall. So when you make that osteotomy slightly medial to the infraorbital nerve,
And the thick
sometimes you might
mucosa,
not even.
and the thick mucosa goes inside.
A limited exposure of the maxillary sinus. Any questions? No questions at all, is it?
All these
I
are all
think they're all
questions
they're all
only, boss.
dumbfounded. I think the speed at which you're doing.
No, don't tell Anna. Okay,
And
that's
so-
all I'm giving exposure. Debrider?
By the way, how is food at home?
Me?
Yeah, he
No,
never
for
takes
Anto.
He always goes
No,
to
boss, not improving at
restaurants.
all. I'm missing my mom's cooking very badly.
Yeah.
He always goes out on Sunday. Today, he sacrificed that. I'm sure his daughter is going to scold him.
Yeah.
Small maxillary cyst. Can you see the interior of the maxilla very clearly, please?
Yes,
Yeah,
yes,
yeah,
yes.
yeah.
That's
And
the
see,
analogy.
over a period of time,
Yeah.
the combination of debrider, the drill, and the coblator,
Yeah,
see the speed and the cleanliness with which you can do the things.
exactly, exactly. Fully agree. Now you can see the nasolacrimal duct there.
Yeah.
Now what I'm going to do is I'm going to drill that. Drill. One advantage in Trichy is I have two people sitting down to change my foot switches. That I don't get when I go abroad. I have to do it myself. It takes time. Here, when I say debrider, there are two people to change the debrider foot switch.
In abroad,
Carburetor.
for every surgery, if you have two people sitting down, after 5 surgeries, you will be the one sitting down. And the wages கொடுக்க முடியாதுப்பா.
See the nasolacrimal duct, please.
Yes, yes, yes.
So
going to
the
transit it.
nasolacrimal duct opens into the inferior meatus for the sake of postgraduates.
It's a real treat to watch. You give a false sense of confidence to everyone that you can do this in a matter of seconds.
Anto,
Yes.
always see this Mountain Dew advertisement, they say first. Please remember, these are the stunts done by qualified professionals. We urge you not to try it at your home or your own operation theater.
No, actually, it's not so. It's not rocket science. Everybody can do it.
I understand. but
actually-
not everybody can do it on the first time.
Yeah, of course. It needs a lot of practice and more of cadaver dissections.
Anto,
Yes, sir.
பிரைமரி ஸ்கூல்ல கடத்து குடிச்சிருக்காரு, பாக்குறது வேற, பண்றது வேற. இப்போ பார்க்கலாம்.
Sir is talking good Tamil, boss. Anto.
Not that question of Tamil. He's in a good mood now. I wonder he doesn't have a fun.
ரெண்டு 60 அடிச்சிட்டா தமிழ்ல வரும், சம்ஸ்கிருதமும் வரும்.
Oh, something went inside to cause this.
No, boss. No.
He had his own fun.
No, but I think there is a stimulant behind it.
That's what. He had his own fun, man.
Actually, to my left side is Dr. Prakash, my senior postgraduate.
And
right side, I have Harihara Murthy, who taught me my tonsillectomy. So it's like, we are in PG class now. So
No, I think all three of you have had good amount of stimulants.
Yeah.
That company doesn't look like, sir.
That is what. That is what I'm telling you. Blexley. Okay, so having gone towards the palatine bone, that's the palatine bone behind it. So you should understand the palatine bone has got a horizontal component and a vertical component. Here we are, debrider, please. See how I'm using the debrider, the cobbler, as Dr. Haldipur sir says, is a combination. It's not just one, but a combination of all the instruments. Now I'm going towards the, see that,
For a minute.
towards the inferior middle meatus.
Anesthesia is very nice.
Come again.
This the blood pressure is very nice because when we do like this, that edge of the the mucosa on the ascending parts of the maxilla will be too high for us to have a good vision.
Janaki,
Yes, sir.
Professor Kirtane has sent a special message for you.
Oh, my
was
God.
He was in Nupur's workshop, but he's watching your
Oh,
demo
so
as well.
sweet.
Only thing is he won't be asking you any questions.
Oh, so nice.
So
sir.
that means
Nice.
your surgery has become unquestionable now.
No. Because he's in another workshop. Please. He's in another workshop. That's why he's not asking questions. Not because the surgery is unquestionable.
வாத்தியார் கீர்த்தனை சாரே சொல்லிருக்காரு பிரச்சனையே கேட்க முடியும்
Sir,
கேட்க முடியாது சார்
you are really high. I understand.
I guess it's the ITC rasam.
That's all. What are you talking? Rasam and all will not cause this.
Rasam is
I'm
mixed
not
with
used to
something,
drinking
boss.
rasam illa.
Janagram, rasam is mixed with something.
That is what I'm telling you. No?
Rasam.
Huh?
ITC Gardenia Rasam, sir.
Sir, Puttamadaya, sir, I told
Yes,
about
sir.
the pepper added there. That's all.
அது ITC அல்ல டொபாக்கோ போட்டிருக்கானா என்ன போட்டிருக்கானே தெரியாது. But it is the rasam effect.
Sir, is ITC Gardenia Rasam.
Now, suction. Okay, so what have we done now? We have done a very minimal. So that's the Harat flap on the other side. Give me a Blexley now. So you can see that I've done an anterior posterior ethmoidectomy. So all these are part of exposure. As I told you, exposure forms around 70 to 80% of our surgical maneuvers. And when you come to the tumor, if it is going to be liquid, you will think, Ayo, idika, did you do so much for just this? But now, because you do this only, that will be easy. So that is something which you have to understand. Sometimes you might think, oh, it's an anticlimax. He has done it so fast. But actually, this will actually help you do that. But this is more done because we don't want to have, give me a elevator. Untoward complication. We don't want to have an untoward complication. Elevator. Normal elevator. Now I'm just going to push this middle turbinate out of my way. So that's the middle turbinate being pushed. Kirtane sir is my teacher. I was with him in 1998. And he taught me. But in those times, he used to do clival tumors and advanced CSF leak procedures. So he's a teacher of teachers. Same way I respect all my teachers in Madras Medical College. Professor Sethi was my mentor. And of course, Dr. Gananand sir, Dr. M.K. Rajshekar sir. So these are names I have to keep telling every day in my life. And of course, now Professor Mohan Kameshwaran sir also. Are you all coming to South Zone?
And you are coming to
Manipal.
Kodaikanal.
Yeah,
Remember,
correct.
South Zone Manipal, sir.
No.
For
This is
our
the-
state conference, sir.
Kodaikanal.
No, that is Tamil Nadu. South Zone is in Manipal this year.
Oh, okay. No, I'm talking about this. Another 1 week we are going to Kodaikanal.
Next week.
Next week. Okay, now what I'm going to do is to take a free flap. Knife. I'm going to take a free flap now. So that I go cross code. Now see here, that is the middle turbinate. This is usually the window which we create at this level. See that? Okay, that's it. Vijay Kumar sir,
Yes, sir.
our neurosurgeon is there. Lovely person. He's like actor Vijay. Scissors. He'll be calm. When it comes to the surgery, then he'll jump and then finish. That tuck like that. This usually happens, sir. Everybody thinks like that only. Now, can you see that I'm taking off that as a free flap, please, all of you? Suction.
Yes, yes.
Now, the reason why I'm taking that is because I don't want to, I can put that as a free flap over the septum. See, it's not that you have to do a reverse flap. Free flaps, you stitch it, it'll take. That's it, finished. Scissors. So there are now gels available. If you are aware, there are gels available where you can just stick it like a gum. It'll stick to the septal cartilage.
Even tissue flaps, tissue cell and the tissue glue.
Yeah.
Okay.
No, there are now specialized gels, coblation. So here, my dear friends, you should use coblation. The reason is you are now dealing with the suction. You are dealing with the
posterior septal artery.
Posterior septal branch of the
Spina bifida.
See that? That is actually the level of the posterior septal branch of the sphenopalatine artery.
This is the 7-3 setting, right?
This is 9-5, sir. 9-5, Anto. Okay, now take this free flap and keep it in saline. See that I have a free flap now, and I'm going to keep it at the end of the surgery over the septum, right?
Yes.
Right. Okay, right. Now, having done that, what next? What next? Suction, please. Shilpi, I'm going to hand over this to Shilpi. I'm going to start doing four-handed surgery now. Now, see here, that is a irrigate, please. Irrigate, Yogender. Blood. Legacy. Okay, now this is the middle turbinate here. This is the superior turbinate here. Okay, right. Now, come, hold. Cross coat, drill. Now I'm going in for the posterior wall of the maxillary sinus. You can see here. You want to go this side itself? You can go this side. Bati. Now see that I will not be doing it like the JNA. I will not go very far. See, constantly being irrigated with saline. See that? This is the key. And always use warm saline, warm saline, warm saline. That will reduce the bleeding.
What's your take on endoscrub?
I don't like it.
It becomes very frothy.
It actually, yeah, as Shilpi says, it becomes very. Can you hear her?
No.
It becomes very frothy.
Say hi to Shilpi.
Shilpi is our key person, boss. Without Shilpi,
That's why I am identifying her.
Her greetings to everyone, she says. See, sometimes even stalwarts stop doing four-handed surgery because they lose their four hands. So I'm lucky so far that she's with me and I'm not stopping four-handed surgery. See, lateral skull base is different. You can do it without the second person. You have both the hands, but endoscopic skull base, you can't do. Especially perforated dissections. So what am I drilling now? This is the orbital process of the
Palatine bone.
palatine bone.
Clip ready, coblation ready.
If any questions come, you can address Dr. Professor Anthony, please.
Fat ready.
You are going to clip spina palatine or both sphenopalatine and descending palatine?
Yeah, both. Of course, we'll have to get the pterygoid wedge now. We can see here. Can you all appreciate it? The bone.
Yeah.
What a beauty! See that?
It's thick.
Yeah, all that acromically. Yeah, and also the medial portion is always thick.
But not this thick. No. Even that posterior wall looks very thick.
Yeah. Correct.
Sir, what is the name of that instrument used to break the?
This is cat's paw, the back of your Freer's elevator. I call it the cat's paw.
But this is not cat's paw.
I call it the cat's paw.
You are the boss. You can call anything. Even you can call it Simran.
What is it that you said? You can call it what?
Simran.
Simran.
Yes, boss.
So what does the encyclopedia call it?
So what does the encyclopedia call it?
Step elevator.
Step elevator, other side, boss.
Both the ways are step elevator only. Other side of the step elevator.
Okay, then I have to. That's a big.
You are an examiner, no, Anto. You should know the correct name.
That's the freest elevator.
No, it looks like the hill elevator. Hill elevator.
Sir, Puttamadaya sir is there. He is the bigger examiner.
Not used.
What a paradox.
Can we rechristian it as the Royal Paul elevator?
Sir, I'll tell you something, sir. Okay. I don't want to hurt anybody, but I'm just telling. Whenever I say some name, no, I say Cottle elevator, something, no. See, 100 times you are telling Cottle. I think why Janagram didn't come? Why people are not telling? Why Indian name Raman, Lakshmi, Sita? Why always Cottle? Some have kept fool's face, yeah, fool. So why like this? I think we should stop asking names first of all, and we should start publishing and telling our names. I would love to call it Agila Sami instrument or Antony's instrument, rather than why are we propagating somebody? Of course, he's an inventor, I know, but then we
are
cannot
already
be
having names, boss.
Agila Sami's elevator. Hereafter, everybody should propagate throughout the world.
No, that sign, no, Bhavagara Janagaraman sign.
No, that's right. But actually, we should have more of our own thing.
He'll come. That's stuck in the transmission.
And somebody was talking about balloon sinoplasty. You know what Stamberger got up and said? And said, why do I feel ashamed? Because why didn't I think about it? Why is Professor Stamberger's name not behind it? And then he said, fortunately, I didn't do it. So this is the kind of attitude everybody has, and we should also, as Indians, see how the sphenopalatine artery is coming like this. Can you see that?
Yes.
Yes.
See that? See that? This is the artery coming like this. I have traced it from here to here. This is a descending palatine artery. Okay, I'm going to take off this part of that bone. Drill. Can you see a beautiful anatomical dissection here? The most important thing is to do anatomical dissections. So what is it I'm drilling right now? This is nothing but the sphenoidal process of the palatine bone. Okay, right. Now what I will do is, later now. Can you all appreciate that, please?
Yes, sir.
Now, you see, I use that ablation mode. See here.
On the stone.
Okay, now give me your ball probe. See, I just made 2 holes in the periosteum. And then I will take off the periosteum. See that hole there? Can you all appreciate that?
Yes,
See,
yes, sir.
once I take it out, can you see that artery now?
Yes.
Yes, Janki, it is very clearly seen.
That's the infraorbital nerve. Can you see that above? This is the sphenopartin artery.
Clip ready.
Clip, please. Clip kuduma. Yogi boss, hold this boss. Okay, I'll do this way. Both arteries have come actually.
Just a couple of years back,
Hold.
you were handling this artery with so much reverence. Now, ipo paatha.
After the advent of mucormycosis, here nobody gives respect to these arteries. Day in and
Yes,
day out, we are
only carotid. Carotid is like Neeraj Chopra. Carotid irundha sonna. வேற பேசாத.
இப்போ carotidல அனிருத்தம் இருந்தா சொல்லு.
Normal carotid எல்லாம் சொல்லாத.
ஆமா. Now give me this one, cobblator now. So I have clipped it. Can you all appreciate that clips, please?
Yes,
So
yes.
I've clipped both the arteries. Now I'm going to delineate the pterygoid wedge. That's the descending part line you can see here. Hey, irrigation kudu. Hey, go closer, go closer. See the descending part line. Can you all appreciate it, please? See that? Beautiful.
Yes,
Can you see the
Janki,
pterygoid wedge, all of you?
Yes, Janki, very clearly seen.
See the median, I've cut the median.
That's
Can you all appreciate that, please? That's the median, that's the V2. Can you all appreciate that, please?
yeah, both V1 and V2.
Yes.
This is V2, that's the median.
That's yeah, understand.
Okay, come out.
The same area in angiofibroma.
Every day in our
keeps
theater,
losing
no.
so much. Yeah.
I always say Kirtana elevator. At least once I will, every day fest when I do, I talk about Kirtana elevator. I'm so proud to say, okay, Kirtana knife, sorry. I stand corrected, Shilpi. I love to.
Dr. Jankiram,
Yes.
one request to you.
Yeah.
That it is a surgery we are not given to watch regularly, and so I will request you to please elaborate the places where you work, where the landmarks you are drilling, the structures gradually being exposed. So that will benefit us more.
Jalaram, orient yourself.
Likely that when you drill the posterior part of the maxilla, you enter that space, the artery that you have clipped. So everything, if you please tell what you have done so far.
Yeah, definitely. So that's the nasoseptal flap, right? This is a nasoseptal flap, okay? Right? Hello?
Yes.
Okay, that's the cut of the inferior turbinate. I'll show you everything now. Okay, since you have asked it, cobblator. Now I will just show you, once I take off this, I'll show you everything. That's a medial pterygoid plate. Okay. Now, what you're seeing here, I'll show you all the anatomy. Now, this is the endoscopic modified Denkers I have done. Okay? Right?
Yes.
Professor, you're from which place, Professor? May I know who is speaking?
I am Dr. Rai from Kolkata. I am not a professor. I am just a ENT
Oh,
doctor.
Dr. Rai, sir, how are you? How are you?
Yeah, you can recognize me.
Yeah, of course, yes, of course, yes. We have done several workshops with you.
Yeah.
Now, you can see here, that is the sphenoid sinus. This is the, see, this is the, I'll show you that. Now, that's the V2. Can you see the V2 here? Foramen
Yes.
of rotundum, right?
Yes. Yes.
Now, this is the Vedian canal. See here, that's the Vedian canal. Can you see the Vedian canal here? It's cut
Yes,
the Vedian
yes.
canal.
Yes.
There's also a communicating nerve here. Okay, this is the, see, from the V2, if you draw a line perpendicularly, medial to it is the pterygopalatine fossa, lateral to it is the infratemporal fossa. This is the IMAX dividing into two branches. I've clipped both the branches. You can see here, I'm going close and showing you the nipple of both. See here, one branch here, one branch. See here one and here one. You can see that I've cut both the sphenopalatine artery and the descending palatine artery. This is the descending palatine canal I showed you. Now, what has happened now is that I have completely delineated. This is the behind that pterygopalatine fossa is the pterygoid wedge. This is the pterygoid wedge. So if I go here, I'll go into the cavernous sinus. Now, this is the sphenoid sinus on both sides. You can see here, this is the owl's eye appearance. Can you see the owl's eye appearance, please?
Yes.
Yeah, that I'm going to show you right now, Cobb later. Now, are you oriented, sir, please?
One thing that please locate the place where the internal maxillary artery is likely to be.
Place of what, sir?
The place where the internal maxillary artery lies. As we have drilled the posterior part of maxilla, posterior wall of maxilla.
I can't hear you. I'm sorry.
Am I not audible?
He wanted to know the IMAX. You can show that area you have clipped and lateral to that, Janki.
Yes, yes.
This is the
You wanted
IMAX.
to know the IMAX. Yeah.
Yes.
This is the IMAX. You want me to dissect that fully?
Yes, yes. Yes.
No, it's not required. Sorry.
Jairam.
It is not required. In this case, it's not required.
No, not required, but this, for general orientation, actually.
Sir, the terminal branches of the internal maxillary artery are the sphenopalatine artery and the descending palatine artery, sir. That's what they have clipped.
Drill.
That is the one we are bothered about in the epistaxis. We do a test called transnasal endoscopic sphenopalatine artery ligation.
Now, what I'm going to do now is expose the sphenoid sinus by what is called the triple osteotomy. That is the osteotomy which is called the planar osteotomy. Come out. Now I keep my suction like this and I keep it like this and go for the shoulder osteotomy. This is called the... See, we never take the scope outside. If you look at it, very hardly we take the scope outside. This is what is called the shoulder osteotomy.
When you have 5-6 skull-based cases a day, you can
What, sir?
do this. If there's only one case,
Are we doing one case?
Hello?
Yes.
AB, sir, tell me. What is it? What is your question? Any questions? I'm also. This is the pterygoid wedge. Sphenoid sinus. This is sphenoid sinus. This is a sphenoid mucosa.
Which always bleeds.
It always bleeds. Correct. So whenever we are taking it out, always irrigate. So keep irrigating. Whenever we are taking it out, keep irrigating. Can you see the bulge of that intersphenoidal septum, please?
Yes.
Yes, yes.
Can you see the bulge, all of you?
Towards the right.
This is the one. See here, this is the warmer. I kept the keel. Now what I'm doing is, you see here. See now, I'm now trying to open up the intersphenoidal septum. Can you see that, all of you?
Yes.
Yes.
This is the keel. No, you're tilted. Ah. So I'm going to retain that keel for Shilpi to get oriented.
For us also.
Dr. Janki,
Yes, sir.
kudos to your anesthesia team.
Thank you,
Because
sir.
it was looking like a wet cadaver dissection.
You don't tell, sir.
The meaning, the oozing is so minimum, as if we are doing in fresh cadaver, you get that little bit oozing. Na? I know it is a live patient, but
Yeah,
such a fantastic level of anesthesia.
Sir, thank you, sir.
Truly masterclass prime time demonstration going on.
Sir, thank you, sir. Vikramji, no? Vikramji. Is that Vikramji?
Yes. You can minus the G part.
It is Vikram Khanna ji.
Okay. Rajesh Khanna, Vikram Khanna ji.
Hello, Vikram.
Yeah,
This is Anthony.
Yes, sir.
No.
Excellent moderation, sir.
Sir, after some time.
Anthony Gonzalez.
Sir, Dr. Vikram. Dr. Vikram.
Yes, Janki.
After some time, you will feel the surgeon is very bloody because you're going to see the cavernous sinus.
It's already started bleeding.
No, that is a sphenoid bleed. Hereafter only you will see real bleeding.
The mother of all bleedings.
Low level. I'll take that. Hop later, please. Now is the time when I'm going to. This is the most sort of concentrated part of the surgery.
You're going to do the cavernous part first, or you go to a supracellular part first? Janagram?
Drill.
Janki, we are anticipating now, quite a bit of bleeding. So what instruments and what all other preparations you keep handy before opening up?
Okay, that's a beautiful question. So I'm having Surgiflow. You can say Flow Seal also. So I'm having Surgicel, Gel Foam. So you see here, that's the pterygoid. Come this side. Now that's the pterygoid beds. Can you see here? This is the V2. Can you all appreciate that?
Yes, sir.
Here. See here. Now I have to drill to the level of the V2. This is what is called the trans-pterygoid approach. See, I'm drilling.
It shows the maxillary crest and the optic strut.
Now you cannot see because the tumor is sitting right over all that.
Okay.
The tumor is sitting over all that area.
Okay.
So you can see the median here. Go closer. Can you see the median now? This one.
Yeah, we could see. Yeah.
Now you go inferior to the median.
Yes.
So where will be the paraclival carotid? Where will be the paraclival? This is the medial pterygoid plate. When you draw a line, it will be exactly corresponding to the medial pterygoid plate.
Yeah.
So because there is tumor there all around, it's very difficult for us to actually locate the carotid now. I'm just placing this part, Shilpi, for you. Okay.
Janki, does the rotate on different sides when you are on the right and the left?
What is your question? What is it?
Does your burn rotate on opposite sides when you're dissecting on the right side and the left side, or it is one direction on?
What is the question? What are the questions? What is the question, please? I can't hear you properly. There is some disturbance.
Does it
Ah.
change when you are on the right side?
Yeah,
and the left side?
direction of the irrigation channel will change. This is a Karl Storz SC neurodrill system, and you see, if I am operating on the right, see how I'm changing my direction now. See that? Now the irrigation channel keeps changing. See how all the three of us are working in tandem. There is no landmark at all. Completely no landmark. I'm just going to create landmarks now. Now that's a V2 here. So I'll be lateral to the carotid here. Elevator. Cat's paw. Now I'm just going to take this. I'm going to take that bone and expose the cavernous sinus now. Can you see the tumor being exposed, the dura?
Yes, yes, yes. Don't you think this is the time to use the Doppler?
No, not now, not now. I'll show you. So I'll show you exactly when to use the Doppler, because now now the carotid is buried. It's inside the tumor. In the
Dr.
center of the tumor.
Jankiram,
Yeah.
the piece of bone that you have just removed,
Yes.
what is that part of the sphenoid?
That is actually the floor of the sella, which has been pushed anteriorly.
Okay.
See that? That is the optic. Can you see the optic here?
Yes.
That's the optic nerve, and that's the carotid artery here.
Yes, yes.
And this part is where the carotid will come here. Right here, you will get the carotid. And this part of the tumor is going lateral to the carotid. So I'll show you all that very shortly. Yeah, give me Surgicel a little bit. Yeah, drill. This is a tricky case. You just can't go with like a normal pituitary. You will injure the carotid. I'm sucking right over the optic nerve. Oh, what happened? See how the tumor is being exposed by us now. Very, 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 very important. I chose this case because this qualifies to be a masterclass case in every aspect. That's why I thought if there is a masterclass, we should give the best case possible.
Thank you, Janki. Thank you for that.
And that is only because of our K. Balachandar, who has maintained the highest standards. He gave me a petroclival cardoma, a frontal sinus CSF leak, which was done combined. I remember all the cases, very, very difficult cases. I said we should have a more difficult case.
ABF Karnataka, sir.
Not AB. He is AB of Pan India.
Oh my God.
Very humble, having achieved so much.
Sir, actually in Telugu they say, Janki,
Yeah.
Aivariki vidyamo ledu, garvamu ledu.
Sir, I'm yet to learn Telugu. Please tell, did you scold me?
இல்ல தமிழ்ல ஐயாக்க வித்யமும் இல்ல கர்வமும் இல்லன்னு.
No. That you're very humble, sir. Don't tell me. Okay, now see what I've done now. I am now exposing elevator. Exposing the whole tumor. Whole tumor is being exposed now. And you can already start that pulsating, you can see the pulsating tumor.
Hold the hairs.
Anna, Vijaykumarna, okay, Anna. Anything I have to do? சொல்லுங்க அண்ணா. அண்ணா எதுவா இருந்தாலும் சொல்லிடுங்க. ஏன்னா I don't want to deal with a fusiform aneurysm. You only told.
I'm an authority in radiation.
Drill, please. Now I'm going for the transtubercular approach. So that's the transcavernous approach which I have done here. That's the transcavernous approach. The carotid is here, right here. I will show you all that now with the Doppler. Before that, I'm just going here. Coblation, Kuduma. Ready, sir? Coblation.
Already distributed.
Is it possible now to define the limit of the tumor?
Sir, anatomical orientation, sir, of the exposure.
Hello, I can't hear you at all.
Can you hear me now?
Anatomical exposure of the tumor which you have exposed just now.
They want to know what all
Just orient us.
Drill. Yeah, I will show you. I'll show you. Now you can see here, this is the cavernous part of the tumor. Here is the cavernous part of the tumor. This whole thing is the cavernous part. This is the cellar part, the sphenoidal and cellar part of the tumor. This is the tuberculum here. This is the tuber. It's all distorted anatomy. That's why you are not able to understand. This is the optic nerve. So I'm going to drill the tuberculum now. I'm going to drill the tuberculum. So this is slightly higher for postgraduates. For postgraduates, it's slightly higher, this case. But for people like KB, I think they will be able to relate to this case.
You are using endoscope of which degree, sir, now? 0 or 70?
We never use angle telescopes in skull base. We never use angle telescopes. Only for visualization we do it. Never for dissection.
কি বললো? না endoscope তো বটে।
So I'm doing a transtubercular transplanar approach to the planum. Go closer. That's the dura.
Was the superior intercavernous is pushed little down?
Yeah, it should be, but I think, see, that's the area of the superior intercavernous, exactly here.
If this case doesn't have the cavernous involvement, when will you do the transplanar or transtubercular? Or when will you do it with the transcellular itself for the supracellular extension?
No, what's your, give me a cat spot. What is your question, Anto?
When will you do the transcellular for supracellular extension? When will you do a transplanar?
Okay, see, basically for rigid tumors, any fibrous tumor which is going supracellular, always do transtubercular approach. Transtubercular approach is the key to descent of the tumor. So that is the first point we should remember. If it's going to be fibrous, if it's going to be liquid, if it's extending very high, there are 5 grades. If you look at Hardy's grading, there are 5 grades. And above grade 3, about going towards the third ventricle, we have to do a transtubercular. And if there are 2 types, type A and type B in the planum. So if I have, that's all classification, I can draw it and show you. If it's going to be type B, then I would do a transplanar again. I will draw it and show you once I...
Janki, there is a request by one of the delegates, if possible, to show how, while doing this four-handed technique, how do the operating surgeons stand outside? You know, how are their positions and hands, if possible?
Yeah, the audio visual, please.
Sir, I want to
Wait, don't do anything now. I'm right on the superior intercavernous sinus. This is superior intercavernous sinus. So there's something called the planum tuberculum angle. If the planum tuberculum angle is more than 90 degrees, then the descent is very difficult. And so essentially we have to do a transplanar tubercular approach. So these are all a little technical aspects. Of course, I don't want to confuse the juniors with all the technical aspects. No, give me a, no, I can't. Give me a, let me check if I've gone till the tuberculum. Yeah, I think
Diagram, there's a question for you.
Yeah.
What is the approximate, which is the approximate area of this talk?
In this case,
yeah.
In this case,
yes.
In this case, it's superior. Always it's superior, and it's towards the left side. Pack, small pack. I think I'm done. I'm going to open up the tumor. No, not so big. I want a lint, neural lint, please. Anna, okay, Anna. A neuro lint kodri. Scissors.
Hello, sir.
Yeah. Please carry on.
Sir, we are from Mysore, sir. Dr. Girish Kulkarni from Mysore.
Hi, sir. Hi.
Sir, it's a wonderful surgery.
Give me a pack.
Going on. We are enjoying it, sir.
Thank you so much, sir. This is actually a little tough case, so I'm a little not talking much as usual because.
Yeah, sir. Before opening, please reorient the anatomy, sir.
Yeah. Give me a good wash. I'll read all of you about the anatomy, what is happening, everything. First, let me first give a good wash. Oh, this is the midline here. Give me a big pack. Give me a big pack, please.
Ready, sir.
Give me a big pack.
Ready.
No. Now I'm going to pack it. I'm going to tell about the anatomy. I'll tell about the carotid, and then we will start. Okay? Right. Now it is 4 o'clock. When do you want me to close? When do you want me to finish, boss?
Till 8 o'clock, sir.
No, but the next dissector is there. No, the demonstrator.
Yeah, Virendra has been given a time at 4:30, Janki.
4:30, is it?
So, yeah. So once Virendra has a short case, then again you resume with the second case.
No, but this will take a little time to finish. That's why I'm asking you.
Yeah.
Maybe 5 o'clock.
You just called. Yeah, we'll send that message to Virendra.
Okay.
Yeah, 5 you finish.
Yeah,
and then again you restart after Virendra again. Okay. Right.
Okay. Now you see. Now to orient you, sir, all of you.
Sir,
now give me the ball pro.
Optic now, sir. Start from the optic now, then we can.
Dr. Siddiq Dana.
Sir, correct, Anna.
Appadi podu arvala. Evde?
Start from optic now and
this is the optic nerve. Can you see the optic nerve there?
Yes, sir. Start from
clearly
there,
seen. Optic nerve. This side, this is the carotid artery. You can see this is the carotid artery. Of course, I'm not exposing the right side carotid.
Yeah,
the reason you don't have to.
Okay.
You don't have to open up the right carotid. So see that bluish carotid artery.
Yes, sir.
Okay, so two landmarks I have now. I have shown you. So again, I'm showing you. This is the optic nerve here.
Yes.
Don't give me a smaller one. Let me. It's only for demonstration. I'm one. Give me a smaller one. Dr. Siddiq sir.
Yes, sir.
I will show you. I'll show you all the anatomy. So wonderful anatomy. Only thing is a little disoriented. It's not the straightforward one. Okay. See, this is the optic nerve. Can you all see the optic nerve here?
Yes, sir.
Same
Right
way.
side.
This side. This is the optic nerve. Here. Okay.
Yes.
You can see here. This is the optic nerve there. You can see that. This is the optic nerve. Now, this is a carotid artery here. This is a carotid artery. I'll just a minute. This is a carotid artery here.
Okay.
This side, I can't see the carotid because it's involving the carotid. When I go this side, I have to remove this. Wait. Give me a black sleeve. Black sleeve, please. I'll remove them. So there is a little mucosa of the sphenoid sinus, which I'll remove. Not coming. Hold, man. Hold. Shilpi, hold. Yeah, I'll just remove that mucosa. ஏமா பிடிக்க மாட்டேங்குது.
Second, let us see. Take the other one. No, why do you want to stumble?
Now I'm just going to take off that mucosa. See, that's the mucosa of the sphenoid sinus. No, suction is not good. Okay, now this is the center. This is the center. You see here. Come down. See here. Can you see that left behind the keel? You draw a line. This is the center. Can you see?
Yes, sir.
Okay, that's the tuberculum which I have drilled. That's the planum. Above is the planum. Can you see the planum?
Yes, sir.
Planum is the roof of the sphenoid sinus. Now this side, you see here, the most important thing is the V2. V2. Can you see the V2 here? All of you? Here.
Yes.
Between my black sleeve.
Yes.
Okay. Now the median will be here. Go closer. See, this is the median. Go inside. Okay, anyway, I'm going to show that median without the median. So between this is called the VR line. See here, this is the VR line. This is the carotid artery. I'm going to show you the Doppler now. Give me the Doppler. I'm going to show you the carotid artery now with the Doppler. It is right in the center of the tumor.
Salve said ready.
Irrigation. Good. Doppler. All of you just see. I'm just going to see your anatomy should be so good. In this distorted anatomy, you should be able to find the carotid, or else you can't do skull base. See here. Now I'll just keep it like a pin point and you will get the. See here. Hey, Edri. Hey, Medwadi, Yenadi Achonadu. Ready? Is it? Okay, see, 1, 2. Can you hear? My dear friends, can you hear?
No.
Sir.
Come nearer. Come close. Hey, Kondari pakatla. Tell me when you can hear, boss.
No,
sir.
we are not hearing.
External.
நீ திட்டுறதுதான் கேக்குது.
Why the Doppler sound?
Keep your mic.
Someone should keep the mic near the Dopplers.
Hey, get the external camera, boss. Why it's not heard? Beautifully heard, boss. Get the external camera. Can you hear me?
No.
You can't hear my voice?
I am hearing your voice, but not the Doppler.
Can you keep the mic near the Doppler, sir?
Can you keep the mic, please, near the Doppler? My mic away, ma'am. You have a mic or not? You don't have a mic. Show. Shilpi, show.
We are not hearing, Janagram.
Can you hear?
No.
Now we can slightly hear, kind of, yeah.
Huh? You can't hear?
No, man, that Doppler's roar, we don't hear actually, for some reason.
I can't.
You don't have hand mic, huh? Hand mic?
What, boss? Why you are not able to? Huh? एक minute. Just see. So I'm going to trace the carotid. Mood ah. You're
Janagram, that sound is not here. That's okay. You.
But anyway, you trace it for us. That's enough.
You have to hear. I don't know why you are not able to hear.
There's a hand mic. Hand mic.
Take one hand mic, put it right over the speaker.
No, but why they are not able to hear, boss? Why?
Hand mic.
We are hearing your mic. Keep your mic there.
Take that mic. Take that mic out. Take that mic.
Take this mic, go near, and then they will hear.
Take the mic out. Keep it on the Doppler. Oh my dear friend.
শাশুড়ি মারা গেছে হসপিটালে আছে তখন মানে কাজকর্ম নেই ওর বউ ছেলে নিয়ে ওখানে আছে বাড়িতে এসেছে বাপকে বাপ করেছে বলছে চারবার বলার পর রেগে মেগে বলছে কিরা শুনতে পাচ্ছিস না এইটা নিয়ে যে আমি এই করি না একদম সত্যিকার ঘটনা আর কি শেষ পর্যন্ত বাংলাতে তো বাংলা বলতো না আমাদের সঙ্গে ওই জন্য চিনি তোমাদের পরের বাস ঠিকই আমি তোমাদের বাস থেকে চিনি না তোমাদের পরের বাস থেকে চিনি
Can you hear me?
Yes.
You didn't hear the Doppler at all, is it?
No.
My God, this is so important to know get the Doppler. I could hear it so well here.
Ma, hand mic, ma.
Okay, give me irrigation now. I'm going to start my dissection. I'm sorry, I'm not able to demonstrate to you the Doppler, but you will see the carotid. You will be seeing the carotid now. Okay, give me this one. Knife, Kappa Bianca. Hey, get all the pituitary instruments. Surgery cell, please. Surgery cell.
Sir, first पिलाओ मत सब ready है आराम से मारो
Your irrigation. Want me to finish it fast? This is the carotid artery. This is the midline. Okay. Now.
नहीं रे बाबा पेट भर गया
Are you ready, all of you? I'm going to open up.
Yes.
Yes, sir.
open பண்ணிட்டு கொடுமா
Now, that's the carotid artery. That's the midline. Don't get fooled because it's dangerous.
Sir, it is possible to put it's a needle and get aspirate and open is best.
Yeah, but
straight away you open.
if you have the carotid in your view, then you don't have to put all the needle and all. If you don't have the carotid in your view, then you have to put a needle. Kasam scissors. So I exactly know the carotid. I have mapped the carotid. This is the carotid here. I'll show you the carotid. You are going to see the carotid.
you have to make it up and then pass now
They don't know actually.
they know everything you're all over stuff because pata is broken
So that's the carotid here.
Correct.
Is this your U flap?
Yeah, because you see, it's not the classical U. The reason is, see, that's the carotid here, right in the center. Okay, so I can't make the classical U. Like usually we make a large U, no? The tumor is sitting right in front of the carotid artery. Going very close to the carotid now. Can you see the U flap here, please, all of you?
Yes, yes.
Okay, now give me the elevator. Rosens. Now it's not a big U. I didn't create a big U. Can you see the tumor? Can you see the tumor, all of you?
Yes.
Biopsy?
Looks like suckable.
Yeah, it's suckable only. According to the, give me a bigger one. Bigger suction, please. 2 suctions. Ready. Ready. Now I'm going to take a biopsy now. The first thing is to take a biopsy. Can you see the tumor coming out? Biopsy?
Yes.
Sir, neurosurgeon, sir. Vijay Kumar, sir. Sir.
Will you take the small connecting dura between that bulging out and the tumor? What you are doing?
No. Give me the Kasams. Kasams scissors. Kasams downturn. Put it downturn now. Now this is the level of the carotid here. Exactly here is the carotid. Now what I'm going to do is to take off that small component in the sphenoid sinus. See here.
Yes.
What is this structure?
This is a tumor only.
Tumor comes out of the
Tumor inside the sphenoid sinus.
Peanut part.
Oh. Hemorrhagic one. Hemorrhagic.
Oh, give. Another suction, please. Suction, please. Ready. Now I'm going for the 2 suction technique.
Have you come to the floor?
No, not yet, not yet. Not yet, because come out, because I have not taken the keel out, because Philby wanted that as a landmark. So I'm going to use my cavernous sinus suction tip to reach the floor. Usually I go end on, but here Philby was insisting that I go for a, see, that's the paraclavial carotid here.
Yes.
See here.
Yeah. One side is exposed.
Give me cavernous sinus suction tip, please. Not cavernous sinus suction tip. Now I'm just, see, all this tumor is inside the sphenoid sinus. I have still not opened the cellar floor. Of course. Take it out. Take it out, no.
Pull it out.
That's the floor. Can you see here?
Yes, yes.
Floor of sphenoid sinus.
The floor of the sphenoid sinus, not the floor of the cellar.
Yes, sir. Yes, sir. Right.
Now I will show you the cellar. When I reach the cellar, I will tell you where I'll be there.
Mopping suction. Intermittent suction.
All
3/4 of the sphenoid sinus is completely filling.
Yeah, the tumor is filling the sphenoid sinus.
Intermittent better.
No, man, there is nothing. They are pulling it so bad. Anyway.
Open one.
Now, what I'm going to do now is, see here. Udupani, Udupani.
I love the tumor.
You love the tumor, but I don't like the aneurysm.
But that's, you have come near that carotid now.
That's the carotid here.
Yeah, that's one. The small bulge is there.
Now I'm going to open up the cavernous sinus. See that? This is the area. Now give me the we have what is called the acoustic knife. Show me. So that level of that's the V2 here. This is the V2. This is the VDN. So I'm going to use my, give me the Kappa Bianca. Now see here, always go lateral to the V2. This is the VDN, lateral to the VDN. Lateral to the VDN, make an incision here. Always this is the way to go. See here, now I make an incision here.
VDN is the landmark for carotid.
সেটা তো অন্য কথা। General knowledge is also interesting. এটা ENT নয় কিন্তু।
Can you see the bleeding there?
Yes.
Now give me the acoustic knife. Now I have to connect that with this.
তোমরা অতটা জানো না। তোমরা ব্রেনে ঢুকে গেছো। যতটা বলেছি।
No, not this, man. Acoustic knife. You don't have the acoustic knife. Not this.
Only nights. Start.
Now see here. See that? I'm going across the carotid artery here. Can you see here, all of you?
Yes, yes, sir.
I'll show you. I'll show you.
Anterior to the across.
Anterior to the carotid. Good acoustic knife. This is the acoustic knife.
Spine chilling.
What exactly is this knife, sir? Can you explain?
It's a sharp knife used to dissect the arachnoid from the acoustic. Now you see, I've gone across the carotid. See that? It's all tumor from the cavernous sinus here. Now, give me the suction now. You will see now the carotid artery end on now. You will see the carotid artery end on now. That's the arachnoid layer of the meningeal layer of dura. See, now give me the, see, this is all the cavernous sinus. Hey, go closer. No, you concentrate on my surgery later. Concentrate in your surgery. Right.
এটা করছি ইনভেস্ট করেছিল কার্ডিও আর্টারিতে
You. No, I want straight. Go inside.
কি গ্লায়াল টিউমার কি?
Vijay Kumar na. Straight suction. So that's all the cavernous sinus part of the tumor. I'm going to show you how we are going to expose the carotid artery now.
Janakiram.
Yeah.
Muthukumar sir is asking, will this cause carotid spasm?
If I see, the patient has got an aneurysm of the carotid. If I handle too much of the carotid will go for rupture itself. Leave alone spasm.
But aneurysms are unlikely to go for spasm.
Yeah, that's what. It's already fully fusiform dilated.
Yeah.
Give me a cavernous sinus suction tip. Now I am almost on the carotid now. I'm going to show you that.
Hello, sir. So what type of tumor you are expecting? This is glioma?
This is pituitary macroadenoma, boss. The acromegaly.
Acromegaly patch. Okay. Microadenoma.
Macroadenoma. Anna, Vijay Kumar na. Carotid artery na. Carotid artery na pathway illana.
No.
Yo, Bhayamar.
பயமா இருந்தா விட்டுருக்கு ஜனகிராம், சுத்தி எடுத்தது போதும். Is it normal?
Dissecting above is cellular part, supracellular part.
I want to tension.
Hello?
Just give me a minute. I'm a little tense.
Biopsy.
Biopsy.
Is on the board.
Okay, now let me answer your question. See here. This is the carotid on this side. Can you see the carotid here?
Yes.
It's going like this. Can you see here?
Yes.
Yes.
That's the carotid this side. But see this side, how big the carotid is. See here. This whole thing is a carotid.
Yes. Almost.
That's a median.
Yes.
Ooh, you see the carotid, Anto?
Huge big carotid.
Like,
And you made it kissing carotid as well.
Exactly.
sir, will you get
In fact,
carotid Doppler
Anto, in acromegaly cases,
Yes, sir.
kissing carotids are more common.
Sir, will you get
In
a cochlear Doppler sound from the fusiform aneurysm of the carotid or
Of
from
course.
the normal carotid only?
No, yeah, both it will get. We'll get both.
Now you can check it, sir, please.
Yeah, I will check it, but you're not able to hear the Doppler. I don't know why.
Sir, you are the master, sir. If you
No,
tell,
boss,
okay,
yeah, audio visual boss.
that is there, sir, but still we are, it is like
Wow,
a king
yeah.
cobra it's sitting in front of the sphenoid sinus. That's what we can understand.
Hey,
from
can
it.
you help me get hey boss, can you get the carotid Doppler, please?
Sir, on Zoom there is a noise reduction, so whatever you do, you will not hear the doctor. Harsha said going on.
Oh, see, there is something called noise reduction in Zoom. Okay. Hello?
Yeah, we understand.
So, Harsha told that any Doppler sound will not be heard because of the noise reduction of the Zoom.
Record that.
Sir.
Play it later, no?
Oh, okay. That I'll do. That's a stock. Wow, see that normal gland. Wow.
That's the umbrella, right?
Yes.
Sir, I have a question.
See, that's the normal diaphragma. Can you see?
Yeah.
Yes, sir.
Is it the Fujita suction or regular ball?
This is cavernous sinus suction, sir.
Okay.
Karl Storrs cavernous sinus suction.
Okay.
Now you see, this is the carotid. See, almost in the midline, you can see the carotid both sides. Can you see that?
Yes, sir.
My God. See, I should not manipulate because if I manipulate, the atherosclerotic plate will get displaced and patient will end up with the infarct.
Sir, good afternoon. Sir,
Yes,
can
sir.
you hear
Yes,
me,
sir. Please
sir?
tell me. Please. Hey,
Sir, I have a question. Is
Please.
it possible to show the first genu and second genu of ICA? And if possible, paraclival part?
I will do that. Just a minute. Let me suck the
sir.
tumor. Then I'll show you everything, boss.
Yeah, sir. Thank you, sir.
Is that a neurosurgeon asking this question?
No, sir. I'm Dr. Anirudh Sarkar, ENT surgeon.
From which part of the world?
Sir, from Kolkata.
Oh, nice.
My thesis guide was, you probably know, Professor Dr. Ashok Kumar Gupta from PGI Chandigarh.
Very well. He's my very
sir.
close friend.
I saw you in PGI. I am very good fan of yours, sir.
Thank you, my dear friend.
Thank you, sir.
Ram, are you sure that you have removed the anterior-most part of the suprasellar extension?
I am doing it slowly, boss.
Are you going to do that Q-tip now?
Yeah, of course. I will do that. Everybody is a little scared of the...
No,
Jankiram sir.
You have gone above that. Then why you bother?
Hello. Hello, Jankiram sir.
Yeah, please tell me.
There is a question. Kindly elaborate the need to expose the V2 and V1.
You don't hold, my dear friend.
And what is the VRN line you were talking about? Please tell its significance.
What is your Budra? Leave it, man. Why are you unnecessarily pulling? Unless I tell you, don't do that, man.
I need a break.
You're overdoing things. Give me a big pack. Anna, Vijay Kumar na. நான் மைக்க வாங்கி பேசுங்கண்ணா. என்னன்னா நீங்க பேசவும் மாட்டீங்க ஒண்ணு மாட்டீங்க. பாருங்க, நான் பயமா இருக்குண்ணா இதை பார்க்க. இல்ல ஜஸ்ட் பேசுங்கண்ணா, சொல்லுங்கண்ணா. டயப்ராக்மா பாத்தீங்களாண்ணா, கீழே வந்துருச்சு. இது பாருங்கண்ணா, கேவர்னஸ் சைனஸ் பியூட்டிஃபுல்லி சீன். பா, வேற லெவல், வேற லெவல்.
பயம் என்ன சொல்றான்? டாப்லர் அவன் என் நெஞ்சில் மேலேயே வச்சு பார்க்கணும்.
Hey, give me a pack, boss. I'm just going to.
ஜானகிராம்,
சொல்லுமா.
இந்த ஆன்டீரியர் இதுவை டியூராவை இன்னும் கொஞ்சம் வந்து கட் பண்ணா you can get the better exposure, no?
இதுவா? இப்போலாம் I don't do too much because the reason is I want to suture it. Suture பண்ணிடுறேன் இப்போலாம்.
Janigram, this is Dr. Muthukumar.
சொல்லுங்க. சார் சொல்லுங்க.
Now you have kept the adult flap ready.
Yeah.
I think most of the tumor has come out, but we are not sure whether we have removed the 100% of the tumor. So in that case, would you surface the adult flap and close the defect, or since there is the diaphragm cella is intact, there is no leak?
We'll use the adult flap, definitely. There is no doubt about it. But even if there is no leak,
if we are not confident of 100% tumor clearance, then can we close it?
Why not? 100%.
Yeah, sir. It can be closed. There's nothing like 100% clearance. You can close it. Okay, one point valid is there is no CSF leak because the dura is intact. Yes, the arachnoid is intact. But still, anyway, now that he has taken
since the carotid is open, we have to close it.
Better, sir.
Okay, can you keep the Doppler balls? I want to show them. Shilpi, come on. We'll do the supracellular dissection, man. Come on.
You have shown the Doppler. We have not heard the Doppler.
Yeah, I'll do that.
We saw the Doppler. We didn't hear
See,
it.
I'm always careful about this, that atherosclerotic plaque which is inside. My neurosurgeon says if it gets displaced, the patient will end up with an infarct. That is more important.
Yes.
Because any problems, see, the problem is not demonstration. The problem is, the result of the patient.
So you're taking so much of risk and showing
not develop any sort of complications when you operate.
Yeah. Wonderful demonstration.
Give irrigation, man.
I totally agree.
அண்ணா என்னண்ணா விஜயகுமார்ண்ணா, ஓகே தானண்ணா? இன்னும் கொஞ்சம் எடுத்துக்கலாம். சுப்ராசெல்லர் ஒண்டி பண்றேன். Suction.
No matter how much it's green.
Suction.
Suction pinch.
அம்மா, அந்த கெரோட்டிட் ரெடி வச்சுக்கோ. அதை எப்படி ரெக்கார்ட் பண்ணுவீங்க? போன்ல ரெக்கார்ட் பண்றீங்களா? போன்ல ரெக்கார்ட் பண்ணாலும் ஜூம்ல தானே போகணும் அது. இல்லம்மா, ஜூம்ல வந்து ஏதோ இருக்காம்மா. There's some, they will reduce the noise. Zoom reduces the noise. அதனாலதான் டாப்லரோடது வர மாட்டேங்குது. Irrigate, keep irrigating, man. Keep irrigating. Last time also when I demonstrated from Hyderabad, it didn't come. You remember, Shilpi?
Suppress noise background low.
Now we'll see. Now, put it. Give me the Doppler now. Shall we try? Or shall I try?
Yeah, try once.
No, I'm asking this audiovisual. I'm asking the audio visual. Oh, okay, give me the Doppler. Let me check. Now, that's the carotid artery.
Yeah.
Yes, we are getting, sir.
Yes, sir.
See, this carotid and this carotid, how narrow?
Yeah.
Show that opposite side cavernous sinus.
Yes, we are more than satisfied.
This is the cavernous sinus here.
Yes.
Opposite side. Cavernous flow.
And here.
Yes.
Yes, sir.
And here.
Yes.
You are hearing, but still that is also very harsh.
See, this is going like this. This carotid is going like this here. It's coming like this. It's coming like
that's
this.
a siphon. This is a siphon.
This is a siphon.
Yeah.
And that's the cavernous sinus lateral to the carotid here.
Yeah.
Here.
The carotid is standing like a pillar in the center. This whole thing is the carotid.
Yeah.
Okay?
Yes,
Now you heard it?
Yep.
Wow, wonderful. Now I'm going for suprasellar dissection. I hope you are able to understand the concept of cavernous sinus clearance across the carotid artery.
Yes,
sir. B2 is helped you to.
No, B2 is the most important landmark. B2 and BDN are the most important landmark for cavernous sinus dissection. Can you see? Can you see the diaphragma descent? Any questions, please ask me.
Why the carotid on the left side is so thick?
Because of the reaction to the tumor.
This is aneurysm, boss, the fusiform aneurysm.
Yes.
This is the inferior hypophyseal artery. Can you see the inferior hypophyseal artery, all of you here?
Yes.
Clearly seen inferior hypophyseal artery.
Yes.
What a beautiful, oh my God, this case. Now I'm going for the 70 degree telescope.
And as they do the auction in Tamil Nadu, this was the Munutharam. We got the carotid in the third attempt by Doppler.
30 degree, please. Now I'm going for the suprasellar dissection. I've done both sides cavernous sinus. I'm very happy about it.
Chalo live.
I'm telling you, I've never seen this sort of case being demonstrated in anywhere in the globe. The reason is generally they don't take such, very high risk cases.
I have to push.
Kuduma, 30 degree kudu.
Is it only seen? Yeah, it's Janki. It's not me.
What?
लगा दोनों का दाढ़ी ज्यादा है.
Daddy.
Hi. My eyes on.
Dr.
Hey,
Jankiram.
Yeah.
Dr. Jankiram.
Yeah.
There is one request to you. They are very much eager to see how the forehand technique is operating by using the external camera.
Zero degree telescope. See how Shilpi is going to. Hey, Shilpi, they want to see the 400. See, here is our. No, don't zoom, my dear friend. See, this is Dr. Yogendra. See, he is standing in front. See that side. See now. This is the hold, Shilpi. Okay, now show the theater. Show the theater fully, my dear friend. Show the theater fully. See here. Now I do like this. See. Can you see, sir?
The surgeon is holding the instrument.
Yes.
In his right hand and in his left hand.
Suction. Can you see or not?
Yes, yes.
Forehand technique.
And you see the assistant on the other side is irrigating.
No, she is holding the endoscope. No irrigating. Oh.
Janagram, this
What?
is called many person forearm technique.
It's a forearm technique, sir.
Okay, now give me the 30-degree. Can you all see that cavity fully, completely removed? Huh? Okay, now I'm going for the Q-tip technique. So this is called the Q-tip technique. I'll show you the Q-tip technique. Can you show Dr. Vijay Kumar coming in? He is our neurosurgeon, Dr. Vijay Kumar.
Thank you, sir.
A great surgeon, lovely surgeon.
Wow.
Yeah, come on. Actually, when he does acoustic neuroma, believe me, nowadays we do a lot of retro-sigs here, and he just finishes it off in around half an hour, 45 minutes, tuck, 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 he finishes off.
Hello, hi Janki.
Hi sir, give me a
Hi Virendra Gaisas here, Janki.
Hi sir, you want to start, is it?
Yeah, if you permit.
No, yeah, I mean, it's up to the audience, whatever they say. I am ready.
No. If you are on the crucial phase, I will wait for 5
Boss,
more minutes.
every step is crucial, you know, no?
Same with me.
We need to be fair to Virendra also. I think 12 minutes, Janki. 5 o'clock Virendra starts.
CIP or
Yeah.
No, believe me, you can shift. I'll be PIP. I love Dr. Virendra Gaisas, sir. I love him. In fact, my son went to him for training also, and he was so nice that he trained Satya. Hey, irrigate, keep irrigating. Why are you not irrigating? Dr. Virendra, yeah, you can start, please.
You can start.
Janki, you have gone too deep.
Dr. Jankiram.
Yeah.
Dr. Jankiram, please accept our wholehearted acknowledgement, congratulations, and thanks for this beautiful surgery.
Thank you, sir. Thank you.
You always mean something new, some magic, some a beautiful gateway to some wonderful world. Thank you so much for this brilliant surgery.
Before I close, Dr. Virendra, sir, just 1 minute. I want to show them.
Yes, Janki. Yes, please.
See here, that's the normal diaphragma here. And if you want to see the normal gland, see, that's the normal gland here. See here.
Yes.
See, that's reddish in color. You can see. That is the normal gland here. This is reddish and vascular. So that's diaphragma and that is reddish. See, with this amount of supracellular extension, no CSF leak at all. So I am very happy that I can close it without any problems or any. See, the anterior part I have completely cleared. Can you see? I think Professor Anthony asked me, and you can see that we have completely cleared.
And I think the closure we can see on PIP.
Yes, thank you very much. Thank you, Alembic.
Thank you, sir. Thank you, sir. Thank you very much.
Thank you, Anthony, sir. Anthony.
Yes, thank you once again.
Anthony,
Muthukumar, sir. Deepak Aldipur, sir. Thank you very much. All of you, thank you.
Janagram, 1 minute. What scope is that?
This is 30-degree.
Okay.
I think
This
I
is 30
wanted
degrees.
a 70, I think.
Thank you, sir.
Janaki,
Yeah.
Janaki, Shamla
Yes.
here. We are thoroughly
Oh.
spellbound with your fantastic, demo of
See
this.
See the aneurysm of the carotid. Oh my God. See the aneurysm of the carotid. The first time we are seeing it endoscopically like this. Thank you.
Thank you, sir. Moving toward our next session, we have Dr. Virendra Gaisas with us. He is going to perform a surgery on tip plasty in Indian ethnic nose. Sir has specialized in rhinoplasty and revision rhinoplasty. His area of interest are rhinoplasty, nasal sculpting, form and function in rhinoplasty and dimple surgery. He has done rhinoplasty training with Professor Wolfgang Gubisch at Stuttgart, Germany from 2005 to 2007. With more than a decade of experience, he has performed 1,000+ surgeries in rhinoplasty. He's also the executive director at the Myanmar Medical College, Talegaon. He is a member of Rhinoplasty Society of Europe and the Indian Facial Aesthetic Society. He is an advisory board of the Indian Journal of Otorhinolaryngology. Now I hand over the session to Dr. Gaisas.
नहीं नहीं करो करो सर ना ಎಬ್ನಾರ್ಜೆ ಎಬ್ನಾರ್ಜೆ
No, very impressed. Super.
Sandeep Dachuri.
Yes, sir. Good evening, sir.
Hi.
Deepak Aldepur, sir. Good evening.
Good evening. Yeah. Virendra.
Yes, hello.
Ek ghav.
Yes, sir. Dr. Deepak Haldipur, sir.
Yes.
Am I audible to you?
Yeah, ek ghav, don tukde.
Ek ghav, don tukde. Yes, sir. Can you, yeah, external camera. Okay. Sir, I am neither in Pune nor in Bangalore. Guess where,
I
sir?
know.
I am in with Anand.
I can see that Niranjan Reddy. Niranjan Reddy.
Yes, I
Belgaum
am with
ka thak.
Niranjan. It's with old Belgaum.
Belgaum ka thak.
buddies. Yeah, Belgaum days again. And he has given me a good ethnic.
The next session
he has got a beautiful
moderated by
setup
our Gautam
of
Ilambardi, sir.
150 bedded,
I request
2 modular OTs
sir, to
and
honor,
cardiac unit. It's
Gautam
amazing, sir. You have to see it. See to believe it.
Yes.
So thanks, Niranjan, for giving the space and the patient, and because
Yeah. Hi,
that's most
Niranjan.
valuable. So it's a wonderful case. Can I show a PowerPoint presentation?
Go ahead.
Good evening, Dr. Virender. I am Dr. Ilambardi from Chennai.
Oh, hello, sir. Hello.
Hello. Yeah. So after mind-blowing surgery by Janaki Raman, we are going to see a mind-calming aesthetic surgery from you, sir.
Oh.
I will hand over the mic to Gautam.
Sir, I'm too superficial, sir.
Your student.
He's too deep in knowledge. I'm too superficial in the knowledge.
No,
That's
no,
a big
no.
difference. So,
Ilambardi, sir, that's a very good comparison.
Yeah. I'm handing over the mic to my son, Gautam Ilambardi, your student.
Yes.
Hello. Hi, sir. How are you?
Hi, Gautam. How are you?
It's been
Good.
just
Congratulations for your first 10 rhinoplasties in a first month. So, yeah, I
Thank
think
you,
Dr.
sir. Thank you,
Sujay is
sir.
also there from Ahmedabad who will be moderating. So, this is the patient, typical ethnic, little brown skin. You can see the thick skin. Patient complaints of a broad nose and a broad tip. You will see from the lower part. No, go back to the first picture. So if you see the entire face, don't think
sir,
of
good
doing
evening.
anaplasty
I
because
just need your 1 minute of attention. In between, as the surgeries are going on back to back, so no space in between. We are really thankful for your time, the way all of you have come in this rainy day and on this holiday, both. So really, sir, we are very thankful on behalf of Alembic Mega Care. But I would like to take this opportunity for one purpose, that we would like to felicitate our moderators who have spent their time and moderated this session. So handing over the session to our regional manager of Kolkata, Rajarshi. Rajarshi, please.
Sir, I think should I continue with it? Yeah, okay. So you can see.
Sir, firstly, I will welcome Dr. Saurabh Chando.
You can
I
see a
think,
broad nose. The distance between the medial canthus and the lateral canthus is same as the lobule.
Thank you, sir. Thank you for your
I
time.
don't think so. I will do a alloplasty here because his face is broad. The next one. So the basal view will definitely show a groove at the just lateral to the tip. So and unequal. nostril.
After Dr. Chandru, Dr. P.B. Roy.
We will go now. What we are thinking of maybe
ultimately moderate correction.
rim grafts and a tip grafts and maybe a one-sided alloplasty. We'll see how it goes. The next photo. The profile looks good. The nasolabial angle is little acute, so we want this tip to go little up.
And
the hump is very small.
Dr. Haldar, Dr. Kamalendu Haldar, please.
We can do after osteotomy or before osteotomy. We can rasp it, or we can camouflage that with a free dice cartilage. The projection is good. The nasofrontal angle is little deep inside, so that will augment. The next. Same here. The next. You can see a typical South Indian thick oily skin. This angle, this groove is good. The other one. This is also good symmetrical nasal creases. The next one. Yeah. Okay. VTOM.
Sir, any CTPNS done, sir?
CTPN is done because patient underwent a surgery, not a septoplasty, a FES, a prior, this almost 13 years back. So CTPNS is done, CT scan is normal. So all the sinuses are clear. So whoever has done the FES is perfect. As Dr. Deepak Haldipur said in the morning, guaranteed FES has been done. And jokes apart, so it's done nicely, so there is nothing in the scan. So we'll start with the case. So I have just marked few things for juniors. That's a medial crus here, the medial crura, then the dome, that's a soft triangle here, then the lateral crura. Also I have marked the midline, and I have marked few, the external camera can come here, come thoda utarna. And I have marked the osteotomy sites also, that will show you later. So there are many incisions, we will go for it. But right now in this case, I will definitely prefer a open septorhinoplasty approach. This I will do it at least, I will say almost in 98% of the cases, I will do the open rhinoplasty or the open approach. This will be a infracartilaginous incision with, so you can see the, just let me know anytime if the picture goes away. So with the alar retractor, I am pressing the middle finger with a finger. You can see the lower border of the lower lateral cartilage here, which is more prominent. So that's the infracartilaginous lower border of the lateral crura, lower lateral cartilage, and that's 3 millimeters away from the rim. So that's the incision. The first incision I'm going to take it, 50 number blade. Yeah, got it.
Sir, you're already infiltrated, right? So
I have already infiltrated.
about the
Also, I have
infiltration.
infiltrated to the, yeah, you are right. I have to show a ropivacaine. Show me that ropivacaine. So I have infiltrated at the points, at the columella, at the incision sites, at the osteotomy sites, and just like any other septoplasty, I have infiltrated on the septum too.
Is it plain ropivacaine or mixed with
No,
adrenaline,
it's
sir?
with the adrenaline. Yeah, you can see with the external camera. Yeah, can you see it?
Down.
Yeah, yeah, yeah.
So
No,
why
no,
ropivacaine instead
no,
of
light mirror.
xylocaine, sir?
Light mirror. Yeah, yeah, yeah.
So
it's
what
a plain
advantage we
0.2
have, sir?
ropivacaine. Yeah, I have added 5 cc of, not 5 cc, 0.5 cc of adrenaline there in 50 cc. Don't
Sir,
ask
what
me the
extra
concentration.
advantage, sir?
Yeah, don't ask me the concentration. I'm bad in maths. So it gives me good field. So
Virendra, they are asking what is the advantage of using.
Acha, oh, I'm sorry. I thought the concentration. The advantage is infiltration is for 3 things. One is to have a painless post-op phase, because the ropivacaine acts for 6 to 8 hours and it will give a good painless field. The second one is for the good field. Is for to get a good surgical plane, and the third one is a good vasoconstriction. So to elevate the planes, I will use the infiltration. For a post-op pain management, I will use it. In the ropivacaine is better here because it acts for almost for 6 to 8 hours. So you can see the lateral crura here.
Yes, sir.
Yeah. So wash mop mat karna, wash karke suction karna. So it's a little blunt scissor, which is the favorite one, which is not cutting any
is invented.
For three things. This post on place from the stainless steel.
So you can see I have dissected the medial crura,
Yes, sir.
the lateral crura, and the dome here. Yeah, clearly seen?
Yeah, yes, sir.
Yes, sir.
Yeah, okay. Yeah.
Sir, we have seen lot of surgeons starting from the columella, but you are starting.
Yeah, because I was born abnormal, no? So I won't do things straightforward. So no, just kidding. See, the thing is this, by this technique, you can preserve the medial crura in a better way.
Sir.
You can dissect the skin envelope from the cartilage and the bone so that the dissection becomes much more easy. It becomes fast and trauma to the underlying structures is less. That's the reason I will prefer this lateral to medial, or the first I will dissect it and then I will take a, with a 11 number blade, I will take a columellar incision. So this is the better approach for me at least. Few of juniors at my place, they struggle with this more. So it's individual choice. Yeah. Wash myself now. Yeah. Yeah. So you can see I have elevated the entire skin envelope. So I have elevated the entire skin envelope from the cartilage.
Yes, sir.
Yeah. Then I will figure it out, which is the narrowest portion of the columella, which is, I suppose, this. Yeah. So, and then I'll take that inverted V and here. So I'm damn sure about it that down I'm not cutting the,
it is behind
the medial crura. So we have Gautam with us.
Yes,
who
sir,
is
yeah.
a pretty junior. So he knows what are the difficulties in elevating this skin envelope once at the start of their rhinoplasty career. Just keep a finger here, right? So,
Yes, sir, yeah.
So you can see the lateral crura. I will change that VTOM stand.
So we can see the abnormality.
Yeah.
Difference between the two.
Yeah.
Both domes are at different heights, sir.
Yeah.
Both domes are at the different height. That I think you saw it
externally
in
also.
pre-op also.
Yeah.
The
Yes,
ala
sir.
was little asymmetrical. So I'm at the, I think I will ask Gautam only to have a commentary, and then I will silently operate. That's a better way. So
Whatever you prefer, sir.
Yeah. So yeah, it has to be two-way. It's not bipolar, please. It's in my hand, my
So
foot.
you can, yeah, we can see that the right lower alar cartilage is
Yeah, that's right.
depressed. Yeah, it is concave.
So this is concave. This is also concave, but this is
Yeah, but
more
it's
deep.
more yeah.
Yeah, yeah. So bipolar, please. Yeah. Thank you.
Sir, one small doubt. This is Dr. Ilambarathi. We call it as alar cartilage or lower alar cartilage.
That's a lateral crus, lower lateral cartilage. Subsparse layer, where all these vessels will be here. And then
Sir, what is the forceps that you are using in your left hand, sir?
it's a cartilage holding forceps. Can you see it?
Yes, sir. Yes, I can see the tip.
Yeah. It's a
Not a
cartilage
routine
holding
action.
forceps. Yeah. It's
Yes.
it's by Medicon.
Adson Brown, yeah.
Yeah.
Shoe holding. Yeah.
Next, I'll hold it. So I'm hold it. No, hold it. ये पकड़ो, ये पकड़ो. I'll adjust the. Yeah. 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 So I'm elevating as close as possible to the bone, as close as possible to that perichondrium and the periosteum there. So, chota gauze piece, wait. Yeah. Which vessel is bleeding there? Yeah. Wash inside, please. Wash. Yes. Give me 11 number blade. Enough. 11 number blade. So I'm cutting. There are two ways of cutting this periosteum. Either vertical in a center, which I'm doing right now, or with a 15 number blade, you can cut it horizontally as well. And then, yeah, section. You just elevate it with the elevator. Yeah.
That's a flag knife from otology set, sir.
So what we are, sir, what
No,
we
no,
are
no.
seeing is the external camera or the VTOM only.
This is a VTOM.
Okay.
Yeah. Yeah, it looks like a flag knife from otology, but that's too small. This is a little bigger elevator. Bigger and a sharper elevator.
Okay.
Who are the moderators there asking questions? So one center is Gautam, another one.
Sir, I am Dr. Sandeep Dachuri from Hyderabad.
Oh, okay. Hi.
Hi,
Perfect.
sir.
So, yes, please. C-shaped. Le lo you. C-shaped system. Right. Excellent. Just hold it like this. And just see whether it's this small oozer. इधर है ये, इधर से आ रहा है क्या? इधर है. That's a typical columnar vessel. Yeah. Okay.
So always it is better to catch the vessels so that it doesn't disturb you or delay it further.
Yeah, delay in bit later on. And especially if it is a VTOM, it gives a magnified view.
Yeah.
And little bit more bleeding. A little bit bleeding, it shows like a massive bleed there. So I'm just cutting a soft tissue so that I can figure it out the deformity of the lateral crus here. So yeah. I'll just spend a little more time. Okay. So ये पकड़ लो और ये पकड़ लो हाथ से. Yeah. So I'm cutting this interdomal ligament and heading
Okay,
towards the membranous part of septum.
Yes, sir.
Sir, can you center the VTOM, sir?
Sure.
We can see only the superior part. Yeah.
Yeah.
Yeah. Even this is also good. Yeah. External camera.
Small mosquito. Yeah, leave it. I think since morning I'm seeing most of the lectures and the surgeries. I think I have saw while coming most of it. I missed in between for few, but then amazing work done by Alembic guys. The way they have managed this, too good. Nahi, chhod do usko. And the previous senior faculty also, they have operated so well, so many surgeries. So
Has he undergone septoplasty during previous FES
That I will
surgeries?
come to know. He has undergone some nasal surgery, mostly the FES. On the scan is showing it has undergone FES. I'll see if I get a septum. If not, I'm ready to harvest a conchal cartilage. But I wish I will get a little more septum. So that's the anterior superior angle. Yeah, now we'll cauterize that columnar. Yeah.
Sir, there is a question.
Yes.
So what is the plan for the depression you have shown for the in the alar cartilage? Right side lower
Depression.
lateral cartilage.
Yeah, what's the plan? Yeah, we'll put unilateral rim graft. No, we'll put a bilateral rim grafts. Cautery थोड़ा कम कर दो. Bipolar का वही कम कर दो थोड़ा सा. We'll see for the tip. I will say we have to start from a midline. Always there is a issue with the spine. The spine has to be in center. If the spine is not center, the caudal part of the septum has to be in center. Then comes the medial crura, the dome, and the lateral crus. So that has to be in line and symmetrical. Then if I go more laterally, it's a lobule part, and the last part is the sill part. So all these part has to be in symmetrical. Then we will get a good symmetry of the nose, of the nostrils, of the tip. So so we have to judge where is this asymmetry, and then accordingly, yeah, the cartilage is friable, but
septum seems to be intact.
Yeah,
no, sir?
yeah. But luckily, I think he has not underwent a SMR like a big big surgery. So it's good for us. We can harvest a little better, bigger cartilage. That's good for us. Maybe we don't have to harvest a conchal cartilage later on, or only one-sided concha.
Conchal cartilage, yeah.
Give me 1 ampule of adrenaline. एक adrenaline इधर देके रखना. Its field is good, but then no, I think he has underwent rhinoplasty or what? Because I can feel there is some cartilage here.
Yeah, some additions.
I thought it's doubling. Let's see. What is it? Revisions are always not always give you some kind of a surprises. Yeah. Can you see this graft?
Yes, sir. Like a stud
Vertical
they have
graft,
kept along the caudal end.
Yeah. So it's not exactly the columnar stud. I think it's some kind of a septal splinting or something. Yeah.
Splinting or extension, something like
that. But it's of no use. Okay, this was the one. We will use it anyway. No, और एक देना हम फिर इधर. That also you give. One more also you give. Yeah. If it is unknown number, forget it. Yeah. So I'm elevating on the opposite side too.
Yes, sir. Sir, we want to know more about the headlight that you are using. What company is it? And
yeah, it's Dr. Kim headlight. The external camera. Can you focus it on the external camera? Can you focus it on my head about the camera? So it's Dr. Kim's headlight. It's from the Korea, and we have Dr. Gautam, who is quite an innovative guy, where he has found out one sister company of Kim
Sir, you want me to
from
elaborate on that?
US. Yeah.
You want me to tell about that?
Yeah, you can tell. So that's a beautiful headlight. Can you see it?
I saw you. Yeah, finally wearing it. Yeah.
Yeah.
Yeah, I can see two lights. Two lights.
Yeah. There are two
It's
lights. So that
shadowless,
shadow is not there, and
And a
it's a
loop.
loop. And it's a
And
loop.
what is the magnification, sir?
It's 2x. I'm using 2x.
Okay. Sir.
And there is a battery behind. Yeah, Gautam, can you talk?
Oh, nice.
Yes, sir. Yeah. So it's called
Yeah.
Biolumix. So it's an US-based company. So they have this. It's the same patent of Dr. Kim. So the only advantage is that it's the battery is different. So it lasts like more than 5 hours.
And
So you
how
don't
much
have
does
to
it
change.
cost?
So
How much does it cost?
Yeah, it costs around 90,000.
Yeah, Dr. Kim is
think,
around
yeah,
60,000.
60, yeah.
Yeah, and this is around 90,000.
Is it available in India, sir?
So I think right now not. The Biolumix is not available, but Dr. Kim is available. So which is pretty similar. It's the same, but maybe only the yeah, correct.
Yeah, but still it lasts for 4 hours. So 2 cases.
Yes, sir. Yeah.
Yeah, but then if you in between you have to change the battery, if you take little more time. Caesar. No, Caesar. I'm looking for Caesar.
So these lights generally come with 2 batteries. So yeah, so you can just charge both the batteries so that you don't have to worry about the light or in between. Even if it goes in between, you can just ask your theater assistant to change it.
So yeah, meanwhile, what I did was I just disconnected the septum from the upper lateral cartilage.
Yes, sir.
Yeah, there's a little tear here. I think there is some kind of a revision septoplasty has been done here. So the planes are not that easy to get it. Wash, please.
Yep. Most of the surgeons, while doing FES, they operate the septum.
Septum, yeah, that's right.
Even if it is in the midline, they just do the septum.
Yeah, wash. That you cannot say, man. There are Deepak Haldipur Janki sitting there. So, bas. Yeah, there is no
sir,
bone
to get
behind.
the space, sir. To get the
there
space.
There is no bone behind. So I'm sure it has been operated. So, but the previous surgeon was so kind enough for us to leave the cartilage.
Septum in front, yeah.
Yeah, so. जो तो एक रोलर गॉज दे देना एड्रेनालिन में थोड़ा सलाइन डाल के या गिव मी स्मॉल रोलर गॉज लाइक दिस और किसको तो बोलना वॉश होने को I'll just keep adrenaline packs there so then I'll get a good feel. The field is anyway good, so छोटा piece. हाँ, perfect. Yeah. One more. So here our aim is to give the patient, he had complaints, mainly complaints of the broad bony dorsum. So our main aim is to give him a narrow bony dorsum, a little finer tip, symmetrical tip, and the notches over the ala.
Okay, sir.
Be taken care of. So that part will do it.
Sir, how old is the patient, sir?
Patient is 40.
Okay.
And yes, you have to always ask. Yeah, it's a good question. Why it's a good question? Because you always have to ask what is the motivation of the surgery, especially at this age. So, but then I have one patient. I have operated my rhinoplasty. The eldest one in my series is 65. So why he really wanted a rhinoplasty was since very long time, since his college days. He was a big industrialist from Pune. And so I'm just cutting, while talking, I'm just cutting the septum. Suction, please. So I'm keeping L shape
L-stud.
and then I will harvest the cartilage in between. So this guy was 65-year-old and he wanted to do a rhinoplasty since his college days, a big industrialist from Pune. And then I talked with him, then his wife came, and then even his wife said he always had a dream of going for a rhinoplasty, but ultimately because of his business schedule and all, it was not possible. But now he's still seriously thinking, which I feel is normal. That's what his wife said. And so he got operated before his son's marriage. So that's quite pretty.
Oh, then it's genuine motivation.
Yeah, the genuine motivation. Yeah. So he wanted to look good. So, and then, yeah, it's nice. So, but it was early 15 number blade. Sorry. Yeah, 15 number blade. Okay, I'll take 11. Give me 15 till now. Oh, it's bleeding. I think there will be a little bit of a bleeding. Yeah. Because it's already been operated. Yeah. Even then the anesthesia is good. Yeah. The BP is nice. So
the picture is gone because I think your headlight or something. Yeah.
It's a bone there. I'm a little slow here because I am able to harvest a gold here. So I don't want that cartilage to be broken. So that's a bony cartilaginous junction. Caesar. Yeah, I've got it.
What is the width of cartilage that you leave in the L-stud?
It's little, looks
centimeter,
like little thicker, no? Looks like little thicker, even for me.
So generally we leave 1 centimeter, sir, caudally and dorsally for the L strut. Yeah.
Oh, I think I'm not able to hear well. What are the questions? I heard what is the thickness of this cartilage? Okay. The thickness, what is remaining behind is 1 centimeter by 1 centimeter. Give me pack now. Hardly any cartilage, but still it's sufficient for our tip. Yeah, give me pack now. Adrenaline pack. We'll just pack it and keep it.
Hello, check.
Yes. Checked and approved. Give me a simple
Hi,
section.
Dr. Virendra. This is Dr. Sujay.
Hey, hi, Sujay.
Finally got through.
Got through? Oh,
Pleasure
great.
watching you operate.
Yeah.
You are a
One more.
wizard, and right from the beginning, word go, you have been great.
Thanks. Section block, bigger section. Give me another pack.
I have seen some surgeons using tranexamic acid soaked gauze. Do you have any experience in that, sir?
No. I think we can give that IV. Locally, I think adrenaline is best. Why to, adrenaline is the best vasoconstrictor.
Yeah.
So, but then, yeah, IV silate or tramelic acid, that pause and all. So everything they give, especially the gynecologist also, they prefer that. Huh? IV, no? IV tramicin, yeah.
But I think that would have to be at least an hour before the surgery, if I'm not wrong.
Yeah, as a pre-operatively while induction or immediately after the induction.
So, Virendra, you do not use adrenaline soaked packs in such situations ever?
Yeah. I just did the same. I just packed it and then.
Yeah, great.
Yeah. Especially it's a revision. So, okay. So, the cartilage harvesting part is done. We will go to the other part. Then we'll think of the mid part, so which is the osteotomy. We may require a little more cartilage. We'll see. In case required, I have already infiltrated on the concha. So in case required, we will harvest one conchal cartilage. Okay, so we will go for the external camera now. So external camera, just come here, this side. Yeah. So then what's the next? After the septum is the mid part, which is the osteotomy. Okay, so you are able to see, I have drawn, this is the keystone area, the cartilage and the bony junction. That's a pyriform aperture. So what I have marked here is low to low osteotomy in the nasophacial groove. And it's a transverse osteotomy. And this line is for the paramedian osteotomy. So actually what happens is, while fracturing, except for the paramedian osteotomy, where I'm going to fracture 50 number blade, I'm going to fracture the nasal bones, the lateral crus, the lateral osteotomy and the transverse osteotomy are not breaking the nasal bones. They are actually breaking up the nasal process of maxilla here and the nasal process of the frontal here. So the midpoint, I'm doing the external osteotomy. So I'm going to do an external low to low osteotomy. So midpoint of the medial canthus and the lobule. In a nasophacial groove, I will take a small cut here.
Sir, if you don't mind, can you explain this low to low and low to high osteotomies and in which case?
I'll do that before doing osteotomy.
Yes, sir. Thank you.
So what happens is in internal osteotomy, wait, yeah. You have this silver chisel. Yeah.
Yes, sir.
So I will go internally from inside. I will do a low side. I will start with the low point. So this is low.
Yes,
this
sir.
medial canthus is low part. Okay.
Yes,
And this is the high part. So I
Yes,
will do a low to low means I will do a osteotomy, which is exactly in the nasophacial groove, and I will stop here. This is low to low. If I do start with low, and if I do like this in between, this is low to high. And I will fracture it so that even this transverse osteotomy part is fractured and the nasal bone is fractured. But in that case, there will be a small part which remains here in low to high osteotomy. So this is low to low, then low to high somewhere here. Okay. And then lastly, we have intermediate osteotomy. In between, you can take it if there is a convexity of the nasal bone. Okay.
Okay. Okay.
Yeah. So I will do low to low osteotomy. So first I will do a paramedian osteotomy. So wash inside and a VTOM picture, please. Wash, please. Yeah. That's. Yeah. Yeah. Can you see it now clearly? There is no bleeding. Yeah. Perfect. So it's a. Where is it? Yeah. It's a 5 mm osteotome.
Yes, sir. Yeah, we can see.
Yeah, it's a 5 mm osteotome. So where is ulta? So where the beveled edge, it's a straight edge. One side is beveled. So that's the upper lateral cartilage. I'm doing a right side. Take a hammer. Right side.
Paramedian.
Paramedian osteotomy. Lighter. So this is the upper lateral cartilage, and that's a septum. So in between the upper lateral and the septum, I'm doing a paramedian osteotomy. Yeah, do it. Tuck, tuck. Yeah, 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 yeah. Wait, one more time. Yeah, so I'm feeling it.
Where to stop?
At the level of the medial canthus. I can feel it here.
Okay, sir. Thank you.
Yeah. Then similarly on the opposite side. So I will show you the fracture line first. Wash. Yeah. Bus. Can you see that fracture line clearly?
Yes, sir.
Yeah. Yeah. Okay. So then I will do the on the opposite side. Yeah. Tuck, tuck. Tuck, tuck. Yeah. Wait. I will feel it. Yeah. Do it. Kar lo ek baar. Bas. So I'm at the level of the medial canthus. Don't cross the medial canthus.
Sir, also, I think you should show the mallet also, because the mallet is a big
Yeah.
saver in
So
these
the external camera, please.
by Medicon, yeah.
Yeah.
Fiber
So two things.
mallet.
Yeah, zoom out, zoom out. Yeah. So it was lying on the judge table. I just got it. So yeah,
It's a wooden
it's a
one, sir.
fiber optic. Yeah, it's a.
It looks like a wooden, but it's
It
fiber.
looks like
yeah.
a wooden, but it's a fiber optic. And what I'm using is a 3 mm osteotome with a handle. So why this big one is, what happens is that entire energy otherwise goes to this 3 mm. So you have a handle there, you have a big mallet there. So what happens here is, with ease, with a very small pressure, you can fracture the nasal bones. Here, the key is sharp osteotomes, sharp edge, because if it is a blunt edge, then you will have unwanted fracture lines here and there. So I've cut the soft tissue here, and then I will do low to low osteotomy. Always commonly asked question me is the lacrimal apparatus and the angular vein.
Angular vein.
Which lies, the lacrimal apparatus lies below the medial canthus. So anyways, respect this, then you won't have any issue. So hold this head. So if you are able to hear the sound, I don't know. So
no, sir, we are not hearing the sound.
Not very clear, no? So I'm slowly.
Actually, we were able to hear when you did the paramedian. Yeah.
Yeah. Okay.
You are making multiple holes.
I'm doing a continuous one.
Yeah.
It's not like a stamp. Previously, I used to do with us like a stamp. Keep bony fragment in between.
It will cause a green stick kind
But
of.
now it's a continuous one till the level of medial canthus. Then I will do a transverse osteotomy. Start from the dorsum. So this is the step which bleeds. But still, I will say the anesthetists have done a great job here. So hardly any bleeding there. Then I will do it on the opposite side.
So paramedian, you have used 5 mm and now you are using 3 mm.
3 mm osteotomy. Yeah, that's right. So ideally, you can use 2 mm osteotome for this. But what happened was, first of all, these are the costly instruments. And I used 2 mm osteotome, and with 5-6 cases only that got broken. Broken in the sense it was turned, and I was not able to do a osteotomy properly. So I got that 3 mm osteotome, which is better. So
Professor Gaisas, do you use the Lindman burr for the paramedians?
yes. So what are the, I was about to come to that thing.
Okay.
So what are the other ways of doing this paramedian osteotomy or the osteotomies per se? As I told, it's an external osteotomy. You can do internal osteotomies with a silver chisels. Paramedian osteotomy, you can use it. You can do it with Lindenberg burrs. You can do it with piezo as well. So Lindenberg burr, let's see, I've got it. Yes, I have got it. So you can see this is the Lindenberg burr. This is the Lindenberg burr. I'll take it out. Yeah. So by which you can just do this. So let's see how much mobilization we have got with this. Yeah. Clear.
Pretty nice. Pretty good. Yes.
Can you get a VTOM picture? So I'll just take out the camera and maybe
I think investing in a good set of instruments is very important.
Instrument is the key.
Essential.
Yeah. Can you see this?
Yes, yes.
Yeah.
Very much narrowed.
So that broad part of this is gone. It was his major concern. Was this.
Yes.
Yeah.
And could you show, can you show the mobility of the fractured bones to make it more clear to all the juniors?
Yeah, yeah. It's completely mobile.
Completely mobile. That's excellent. That's difficult to achieve, but very beautifully done.
Sir, the VTOM is moving rapidly. Can
No.
somebody stabilize?
I
it's
removed
a
the
VTOM
camera. I
or-
removed the
Oh,
camera.
okay.
But I hold it in my hand. So
Yeah.
yeah. Yeah, that's the minute. Okay. So profile also you can show. Side view. थोड़ा side से लेके आ जाओ. I'll go down.
Sir, you're going to keep the ice or ice is not there?
Sorry?
The ice. You're going
The
to keep
ice,
the bus?
yeah.
Or no?
Yeah. So there's no ice, but generally नहीं नीचे से लो.
Yes, already much better profile.
Yeah, much better profile. Wait.
Yeah.
Sir,
Wait,
is
the
there a
camera is going
small
down.
hump?
Camera is going down. Yeah, sorry.
Sir, there is a question. Is there a small hump?
Yes.
Yeah.
Preoperatively also it was a small hump.
Sir.
See, the nasofrontal groove was deep. So previously also there was a small hump which I have not removed it or not rasped it. So दिखा दो profile. Yeah. Center पे. Center the picture.
Yeah, we can see the nose has become narrowed.
Yeah,
And
it
the
has
hump
become
also.
narrowed.
Yeah, dorsal height.
There is little
improved
bit,
a
yeah,
lot.
there is little bit hump there. Side view, profile view, please. Yeah.
Yes,
So
sir.
the little bit of a hump there. So now what
Yes, sir.
happens is we can do a free dice cartilage here and camouflage this
Or we
rather
can-
than reducing this because there is already we have to augment little bit.
Yes, sir.
Either you can do a rasp previously before
or
osteotomy.
cutting.
Yeah. Now you can cut with a scissor or you can do it with a diamond burr, but just camouflage this part with a cartilage and
Yes,
no
sir.
need of removing this very small hump. This is hardly 1 or 2 millimeter. So don't
Yes, sir.
remove always. Yeah. Yeah. So then we'll focus it now to the tip part. Yeah. So the VTOM. Yeah. Okay. I will go a little behind. Yeah. Okay. Right. So what we will require here is columnar stud, tip graft and shield graft. Okay. So let's see what we have got. External camera here. नहीं ये नहीं. External camera here.
You have to show the graft. Yeah.
Yeah.
Then you're not putting spreaders, no?
No, because the
Because
T
of
was
the
good.
T was big.
Yeah.
Okay.
Yeah. So I'll explain you. 11 number blade, please. Yeah. Patti scale patti है ना इधर. Yeah. मिल गया. Yeah.
So Professor Gaisas, we missed out a bit during the session. Did you leave an L strut or have you got
Yes.
the
Yes. I lived the L1.
Right.
L behind. Yeah. So that's for columnar stud.
Yeah.
This part which was kept, I'll use this as a rim.
Okay.
Yeah. Then for the tip, I will go for a dorsal onlay graft. So I will cut two square pieces. So this is for a dorsal onlay graft. Yeah. So columnar stud, rim grafts, and 2 dorsal onlay grafts. Yeah. I think I will use only this for the tip. The rest will be diced.
Okay.
Fine.
Okay.
In case after if I feel this is less, I can always harvest a conchal cartilage.
Okay. Sir.
Okay. Yeah.
Sir, there is some technical issue in Hyderabad. We'll be disconnecting for some time.
Sure. Okay.
Okay. Thank you.
I'll do it slowly so you won't miss anything. Yeah. So उसको बोलना इसका खीमा से छोटे-छोटे pieces बनाने. Yeah. Morsel ऐसे छोटा-छोटा with 11 number blade. 11 number blade. So yeah, take it. Yeah, so ऐसे करके छोटा सा, इतना छोटा सा, that small pieces, huh? The entire cartilage. Yeah. Yeah, all the cartilage. We have take out the here. Caesar. Okay, so now if you see profile, the basal view. Wait, I'll just adjust that VTOM. Yeah, because
Yeah, it is like
here is what happens is now the VTOM is not in center. You will always feel
it's deviated.
it's one-sided deviation.
Correct,
Yeah. So yeah. Okay. So this is equal now. Yeah.
Yes, sir. Yeah.
Wash. Yeah. Excellent field done right now. So give me Caesar. Yeah, it's here. So I'm creating a pocket. Now you can see there was a little deviation here, and you can see this is a twisted here, right?
Yes.
Sir, yeah.
So we want to make this straight. So we will see what is wrong inside, why this is deviated. So first we have to see this spine. So that's a L, which Sujay, that's a L, we have kept it behind. Yes.
Yeah, I can see it clearly now.
Yeah, yeah. So I will just disconnect the septum from the spine. And I will relocate it little anteriorly.
Yes.
Okay. So that's a bone there. So columnar stud has to touch the bone down. It should not be a take a chair,
Hanging one,
Niranjan.
Floating one.
No,
yeah.
no. Otherwise, your back will go off. Take a chair and sit and do it. Yeah. So I'm just putting a columnar stud. Give me 26 number needles. 26 number needles. Oh, voila. One more or ek do. Sorry. So I'll fix that.
So this strut is placed anterior to the anterior nasal spine in a pocket.
That's right. That's right, in a pocket. That's to give a tip support, because we are
Yes.
going to put a tip onlay tip grafts.
Yeah.
Now, why not shield? Because if I see from the profile, so there is a columnar show already. There is a nice columnar show. So if I put a
Don't want to make a hanging
shield graft there,
column.
then there will be more columnar show.
Yeah.
So if the columnar show is nice, then go for a onlay graft, dorsal onlay graft. So that's a 50 PDS, and that's a 50 PDS.
Yes, sir. Yeah, we can see it.
Yeah, yeah. So otherwise, go for a shield graft if there is a columnar retraction. So the reason the incision, the marginal incision here is down, because this suture gets hidden in the skin. If the incision ends at the inverted V incision at the columella, then this fixation, the knot is visible, which is outside the skin. So that's the main reason I take that marginal incision little down. Chota, yeah. Perfect. Nick, wash karo.
The columnar
So-
strut, the inferior part is it is inside the needle. Needle is inside that.
Yeah.
Okay.
Yeah. So the columnar show ideally also should take care of this columnar or the medial crura deviation.
Yes, very true.
Yeah. If it is not, then I'm in trouble.
It appears to be straightening the whole thing. Yes,
Yeah,
columella.
like, yeah.
Are you planning on a supramedial resection of the lower lateral as well?
Yes. So lower lateral, I won't resect it.
Yeah.
I will undo a underlay, the infold it.
Yeah, very true.
Yeah.
Because there was a concavity.
Strengthen it, yeah, because there was a deep groove also there.
Yeah, on the right side.
On the right side, yeah. So we'll take care of that groove
Concavity,
also.
yeah.
But then, surprisingly, the groove was. Can you show us the laptop, the photos, pre-op photos again? Just see the oblique views, right and left. The groove was not even
visible.
pre-operatively. The
Not
groove was
visible.
not asymmetrical.
Yeah.
Okay. Yeah. Yes, sir, yeah.
Yeah, we'll see again. We'll see again. Yeah. Next one. Yeah, here, no. Here there is asymmetry.
Hello?
That's because the medial crura is deviated.
Hello, Dr. Gaisas.
Next one. Yeah, just a minute. Next one. Next photo. Next photo. Yeah. So here you will see that groove. Next one. And this is the groove. Yeah.
Yeah.
The one photo back. Yeah. So it was not asymmetrical.
Yeah,
there.
it wasn't visible.
Yeah. But then still it is too deep. So we will definitely
And her
strengthen it.
skin, texture
Yes.
was quite thick.
Someone is
So
asking
maybe
me
that was the
questions.
reason.
Yeah.
Hello.
Yes, sir.
How should we place the columella graft, vertically or a little obliquely?
Sir, your voice is little muffled.
How should we place the columella graft, vertically or little obliquely?
Vertically.
Vertically or obliquely? No, it depends on the direction of the columella or the medial crus, and where is the spine is. So here like that, here is little bit obliquely placed.
That's why I'm asking it.
Spine, yeah, because the spine is little behind. The bone is little behind. So ultimately it has to give a good support to the tip. So that actually matters. So exact vertical or it does not matter. It should be ideally give a good tip support. So then I will do a tip sutures. So I will go medially. Is it center? Yeah, it's in center.
Hello.
Medially to, so I will
Hello,
divide
Dr.
this
Gaisas.
Yeah.
Is there any need to fix the that is cartilaginous start with the periosteum of the spine?
Periosteum of the spine? No. You can directly suture it. This graft is anterior to the spine. Spine is much behind. Septum, you can suture it to the spine, which we very often we do it. Not to the periosteum. We will directly drill the spine and we'll fix up to the bone.
Okay.
Yeah. So because periosteal fixation is vague, it's not that accurate and it can slip on. So better to suture it to the bone. So I'm suturing this dome. I'll take this half. So midpoint, I'm just suturing this medial to lateral, then lateral to medial. On the opposite side also, medial to lateral. Then I will come from the opposite side, lateral to medial. So the knot becomes, it gets hidden inside and the suture is symmetrical. And ultimately you have little diamond shaped here. So that matters if the skin is really thin. Here the skin itself is so thick. So it's not going to bother much. Yeah. Sorry. Yeah, that one also. हाँ चलेगा. नहीं, more smaller is fine, but this is okay. This is perfect. Yeah. Take a C shape, please. Yeah. Then I will suture this lateral, upper lateral cartilage to the this septum ka T, which is quite healthy. Yeah. And then after that, we'll come to the lateral crura. I will adjust the VTOM so you will be able to see nicely. Yeah. Okay, let's adjust the VTOM. Maybe lose करो ये हिलाना है मुझे. Just lose this. No, not this. ये lose this. Yeah. Okay. Tight it. Yeah. Yeah. This is clear. This angle is better.
Little bit center, sir.
Yeah. Yeah.
Yes, sir. Yeah, but it's, I think, focus.
Yeah.
Yeah. Yes, sir. Yeah.
Take a tuberculin syringe and put it inside. So that bag has got insulin syringe or tuberculin syringe. Yeah. So this is around 1 centimeter. So 1.1, 1.3. So around 3-4 millimeters, I can still do upfolding. I can cut and do infolding of that. Not much. ये वाला. 11 number blade, please. Take out the.
Hello, Virendra.
Yes.
Hello, Virendra. Good evening. This is Dr. Gaikwad here.
Hello.
Hello.
Yeah, I'm listening to you.
Virendra, मला विचार आता ते फ्लश केलंस ना?
हो. Hello.
Is it a cold water flush or the normal room temperature? Saline?
It's a normal saline flush.
Normal saline, no? Okay.
Yeah, it's a cold saline, little cold saline, but it's a normal saline.
Fine.
Caesar, sharp Caesar. Yeah.
Okay, thank you.
Thank you, sir. Which center? Where are you?
That was Dr. Ninad Gaikwad from Mumbai.
From Mumbai. Okay. So.
And this is Vikram Khanna.
Oh, hi. Hi, Vikram. How are you? Still raining in Mumbai, no? Still raining in Mumbai.
We are here from 8:30 in the morning. So what's happening outside? Absolutely no idea. But
wow,
the master class is so mesmerizing that.
Amazing. That's superb. Give me needles. So you can see that I have done a cephalic trimming and I have yeah. I have elevated the vestibular skin. And I have put it down. So ultimately it will be strengthened one other needle. Lost. Yeah. Yeah. So can you see the difference between two? Now this is much more stable.
Yeah, and it's become
that
more
convexity. Yeah, the concavity is gone. So it will have a better nasal crease. I think the Alembic people they are doing a great job. I think Rajat, we have Shweta here. So coordinating from Anandpur. Rajat, I think, is doing the entire India, pan-India head. So I think 41 to organize live transmission from 3 places and 41 centers across India is not a joke. So even the audiovisual guys are so professional. They're so good. So we cannot even think of operating at 3 places and transmitting at 41 places. So great. And then each center has got amazing moderators.
And the best part is such clarity in all
Such a
centers.
clarity.
It is
Yeah,
wonderful.
yeah.
Hello. Hi,
Hello.
Virendra. Jyotsna here from Thane.
Oh, hi, Josna.
Excellent demonstration you're doing.
Thanks, Josna.
Yeah, there are a few questions. If you permit, I'll ask questions.
Yes,
There
please.
is- yeah, there is one question that what is your take on using septal extension graft over columnar strut in this case? This
Yeah, that's right. So I'll answer that. It depends. See, it depends on the availability. The question is right. Septal extension graft would have been a better choice if the cartilage would have been there. Otherwise, operated case for a septoplasty, I got a small piece. So either I have to do a conchal cartilage. Again, the conchal cartilage won't be sufficient material for a septal extension graft. Then I have to go for a rib. So for a reduction rhinoplasty and finding this, a rib is, and again, you have to think about the age. Good chance that it will be ossified rib.
Yeah.
So again, your purpose won't be, sorted out. So technically, even the columnar strut will give equally, not equally, but a better tip strength. Of course, the septal extension graft will give a better strength, but that I will keep it for very acute or very less support to the tip, and especially in the revision rhinoplasties, I will definitely go for a septal extension graft. But because of the cartilage is less and rib probability of ossification, I have gone for the columnar strut. But extremely good question. Yeah. Yes, Josna.
Yeah. So this is from Dr. Shubham Agarwal. There is one more question. Is there any precaution to avoid area injury, keystone injury, K area injury
K
in
injury,
paramedian
right.
osteotomy?
For paramedian osteotomy. Yeah. Again, the thing is you are lateral to it, lateral to the septum, parallel to the septum. So there won't be any direct displacement of the septum unless until if you have a really blunt osteotomes. So if it is a blunt one, then you will have fracture here and there, and then your septum can come in between, or septum can get dislocated. It's not always that septum gets dislocated because of blunt osteotomes. Sometimes there is a very deviation there and very weakening of the cartilage there because of the deviation. In those cases, you will have weak keystone area, and then chances of the displacement of the septum happens. But if you know the extracorporeal septoplasty, if you should know how to drill the nasal bones, then you should not be afraid, or the partial extracorporeal, to suture it back so that there is no issue there.
Yeah,
I
and
hope I
if
have
there are, if you're removing the hump at the keystone area, maybe at that time there are more chances of.
So that's what. So while removing the hump, take it out, take the needle out. I have taken the one so that while removing the hump, so if you have done it little with a blunt instruments, you are going to dislocate it, dislodge it, surely. Yeah.
Yeah, that's all.
Hello.
Okay.
Hello, Virendra.
Hello. Yes.
This is Dr. Gaikwad. I just wanted to know the material that you're using, is it absorbable or non-absorbable material?
Okay. Dr. Gaikwad, I didn't realize Dr. Gaikwad.
No, it's
If
all
you
right,
have to
sir.
say Ninad. So
Okay.
you're famous all over India as Ninad.
No, it's all right, sir.
So sorry.
wanted
I'm
to
using
know-
50 PDS. I've just shown you. I will show you again. It's a absorbable material, so which
Right.
gets absorbed little late It has got very less reaction. Yeah, 50 PDS with reverse cutting needle. Yeah, the cut needle is good. This is the number 9872 because this has got, even then this is 50, the needle is big, right? Otherwise you will find that you will get a 50 or 60, the dyed one with a very small needle. Then it's difficult to suture, it gets bent. So this code number has got little better needle.
Yes, sir.
So you can see now, I'll go back again with the previous.
Okay, thank you, sir.
No. Yeah. Okay. Now you can see the columella is straight.
Yes, sir. Yeah.
Yeah,
Hello,
this
Dr. Viren.
columella is straight. Should I go still down?
Yes, sir. To
Hello,
to
Dr.
get a
Viren.
clear picture.
Yeah. Or I will ask the external cameraman.
Good
to go
evening. I am
down.
Dr. Rajiv Dhawan from Delhi.
Oh, hello.
I am Dr. Rajiv Dhawan from Delhi. Just
Yes.
wanted to ask about what are the precautions to avoid injury to the lacrimal apparatus and how to deal with it?
Sorry. Avoid
Injury to the lacrimal apparatus in the
lacrimal
paramedial.
apparatus. Yeah, I answered that while doing osteotomy. The main is respect medial canthus. If you respect the medial canthus, then there won't be any injury to the lacrimal apparatus at all. So yeah, you are seeing the external camera now.
Okay, thanks.
Yeah. So the columella is become straight. Sorry. Yeah.
Yes, sir. Yeah.
Yeah. The columella has become straight, but you can definitely see. You can definitely see a weakness here. Yeah.
That will taken care of by the
Taken
rim
care
ka.
of by the rim ka. Yeah.
Yeah.
So this will be by the rim. Thoda teda hai kya? The angle is little.
The tip is also much
From
narrow.
the camera or
some elevation as
we
well.
turn from the center, sir, because
Yeah,
it gives
yeah,
an
yeah.
appearance like
External
that.
camera is हाँ थोड़ा center से लाया तो अच्छा हो जाएगा. So meanwhile, till he gets
Better.
that, so I will cut this skin here.
Soft tissue trimming, yeah.
Soft tissue trimming till you see white. ये पकड़ लो. Yeah. ये लगेगा बाद में. Keep it. So you should not go that deep. Respect that white thing. Otherwise, what will happen here is chance of skin necrosis there, which we do not want. So you can see this white stuff coming. That time I will stop. Yeah. Yeah, take it out. So suction.
Dr. Gaisas, do you feel this trimming also takes care of the usual tip, edema for a much longer time otherwise?
Yeah, that's right. Otherwise, it takes this thick skin takes so much time.
Yeah.
So, definitely. So generally, I've tell full 1 year for thick skin. Yeah, full 1 year. Yeah. So now you can see. I think we can take out the light from down, or you can see that.
Yeah, the tip is
Yes,
much
sir, yeah.
narrowed and much elevated also.
Yeah,
already.
much elevated also.
Yeah.
We will give him a little better, more sharper tip.
Exactly.
So no doubt. Yeah. So, but now that because of our simple columnar stud and because of I think the lateral crust strengthening, this has become much more healthier and better.
Yeah.
Yeah. So we will go for 2 dorsal onlay grafts now. Yeah. So yes, you can give a VTOM picture. Please give a VTOM picture. Yeah. Sorry. So I will see if maybe I'm feeling this 2 will be a little more for him.
Mm-hmm.
So we'll see. I'll just suture it and then we'll take a judgment. So I'm starting from one side. Going on the other. Yeah, you can. This 50 PDS gives a less reaction while absorbing. It will get absorbed somewhere between, and few literature says is 100 days, few says it's 300 days. So, but then like unlike Vicryl and catgut, this will get very less reaction while getting absorbed. So the pain is less. If you put a Vicryl, patient will still have it's a painful tip later on if you have taken a Vicryl stitches. So maybe you can take also, if PDS is not available, maybe a Proline, but don't use Vicryl or a catgut here. Yeah. Okay. So that's a suturing. A camera, external camera again. Yeah. Block होता है बीच में। हाँ, हो गया। So I'll retract the skin. Yeah, better.
Yes, sir. Very nice. Yeah.
Definitely.
Maybe the lateral view also. Maybe. Yeah.
Yeah,
Just-
surely. So definitely a better. This is here, so I'll just suture it here. Yeah. And then also again we have to put a rim. Then we'll put a rim. So it, and then we'll see even after putting the rim, if so we have made everything in center, everything symmetrical. Even in spite of doing that, if we feel this one-sided ala is unequal, then we will do alloplasty.
Alloplasty.
Yeah? So doesn't look like I will require it, but that should be the flow. So that's parallel to the rim. I'm doing a small pocket. Yeah. Yeah, that's a rim cartilage, rim graft. First, I'll put it on one side. No, external down camera. VTOM is little deviated. External, ye wala, external camera. Yeah. So
The depression has gone. Yeah.
Yeah, the depression is
Thickness.
gone. Yeah. So we'll put it here on the opposite side. Yeah, you can see now this is much more healthier, right? Previously, if you have seen this is
Yes,
this
sir.
was little weak. Now you can see this is much more healthier and better. Yeah, and much more
Even the soft
straighter.
triangle is looking much better now.
Yeah, much more straighter
Yeah.
as compared to this oval part here.
Yeah.
Yeah, so ये टॉप लाइट थोड़ा नीचे से दिखाते हो, so because थोड़ा अंधेरा आता है ऐसे, that's what I feel. So हाँ, थोड़ा नीचे से और थोड़ा नीचे जाओ. Wash.
Yeah.
Yeah, yeah. Yeah, external camera.
Yes, much better. Much
Yeah?
better. Yeah.
Much better, right?
Yes,
Very
sir.
good.
Then I will suture it like this. So once I'll just take one stitch, and then we'll see
Then
whether
show the
we want to do
profile.
alloplasty or not.
Okay.
Either needle holder. Yeah. Hmm. So, थोड़ा ऊपर से दे दो. No, no. Or I will adjust that VTOM. Or I will take out that camera. I'll show you with this camera. No. Your view is better. Yeah.
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 Yes,
I
sir.
don't think so. I have to do
Yeah.
alaplasty.
Even I wouldn't touch the Ella now.
Yeah.
It's
No.
pretty
No,
nice.
sir. Maybe a very little disproportion.
Very
but
little difference. Yeah. I think risk versus benefit is in favor of not doing anything.
Not doing anything. That's right. No, because it's like if I do it, then
Maybe the
I can create another deformity by
Correct,
doing
Very
it.
true. Very true.
Yeah.
So the
So-
risk is a lot more than the benefit. It's not required, I think.
Yeah, that's
In
right.
my this thing.
Okay. Perfect. I love Sujay.
The love is mutual.
So then I have got a very small free dice cartilage, hardly anything,
Okay.
Just
which
for
I
the
will put it in
depression.
a naso
Supratum.
front. Yeah.
Both sides of the
supratum.
hump. Yeah.
And then
Sometimes.
let me check. Yeah. Okay.
Hello,
Oh, that's
Hello.
just come out. Yeah.
Dr. Virender,
Yes.
Dr. Ishwar from Delhi. You
Yes,
have done a
sir.
good job, appreciable. But
Thank
what
you, sir.
about the shape of the nostril, opening of the nostril? Are they symmetrical?
Yeah, that's what we were thinking. That's what we are judging. Whether they are symmetrical or not, and whether I have to do alloplasty
One
or
looks
not.
to be elliptical, other is oval.
Yeah, that's right. So that's what we were wondering to do alloplasty. Wait, do it or not? I will require. Yeah.
Only the
Oh.
left side, the sill is.
Left side is
Yeah.
little bit. Yeah.
Sill is
So
longer,
And
yeah.
then septum also left side, it's more protruding that where your suction is left.
that's
That side.
wait,
If you
I'll
see
just
from the
suture it
down.
and then we'll discuss it again. I'll just suture everything.
Yeah.
So because inside we have done everything symmetrical.
Yeah. No, the
So
it
the
has
only
improved
issue remains is-
markedly, but at your hands, the thing should be more symmetrical and
Yeah, that's right. So after suturing everything, we will see if I have to
have
do
a
something
second look.
here and take care of it. We'll see. So closing means I'm not closing the case. I'm just closing the nose to see the judgment. Wash, please.
And I also feel that the external camera, sir, it's giving a slightly tilted,
Tilted
angle.
appearance.
Yeah. So
No, I will ask them to come from
yes,
this side.
center. Yeah.
And then, and then we'll see again.
Hello.
No, it's not the only camera. It's me also with a direct vision. I'm seeing there is a difference between two Ella.
That is
So
there, yeah.
it's not only the camera. So
Septum
yeah,
part. Yeah.
tilt it here. No, tilt it on this side. Yeah.
Hello. Good evening.
Yes.
Good
Wash,
evening,
please.
Gubesh sir. Good evening.
Hey. Hello. Who is this?
How are you? I am Dr. Vijayendra.
Vijendra, I thought so. Sir, kya Gubish bol rahe ho, sir?
So what is the suture material you are using?
Yeah. So right
Hello?
now this is Vicryl.
Oh.
Yes, Dr. Vijendra, sir.
I am enjoying silently from last 1 hour. I am seeing beautiful.
Oh, thank you, sir. So I know you are a great rhinoplasty surgeon too. Apart from a great otology case we have seen in the morning from airport to the place, I was watching your case. So
thank you.
Yeah, and same thing I was discussing. I was surprised to see in otology. In rhinoplasty, we see such patients and we refuse lot many patients than saying yes. But it is
correct.
started happening in otology also.
No, that was a fact I have told. I was disappointed. That was a very nice case.
Yeah.
So I was so reluctant.
Excessive demands, unrealistic demands is huge
That-
problem in rhinoplasty. So, but even otology, yeah. So
Probably I adopted them free of service. That is the thing. If you charge, they will know the value. When you tell free, no. That is
Right.
also, yeah, it's a fact.
Yeah,
When you
that's
do
right, sir.
free, it doesn't have value.
That's right, sir.
Now, this which camera you're using? How you are using? Headlight camera, is it?
No. This is the external camera. Why it's looking teda oblique? Why it's looking oblique?
So throughout you're doing through the external camera, is it?
No. It's VTOM, sir. Can you show us a
VTOM.
VTOM?
Okay.
Can you
Yeah.
focus? Zoom out. No. Not VTOM picture. External camera. Show this VTOM stand. I have to take a party from Mubarak Khan or I have to give it also because this stand is by Mubarak. So
yeah, that's what I was wondering.
So that's a
Nice.
stand which is a malleable like a gooseneck.
Okay.
And you can adjust. This is a VTOM. This is a 5 mm scope where the camera is attached.
Oh,
So it gives a wonderful vision. Now you can show them.
Yeah, that's what I was
VTOM.
observing.
Yeah. So that's a VTOM.
That is a striker camera, is it?
That's a striker camera. Yes, sir. Yes.
I think 1488. Okay.
Yeah. And that's a vision it gives, VTOM view, VTOM picture.
But when you're doing it, will not come, the hands and all will not come in the way.
Yeah, it won't. So that's a VTOM picture, sir.
Yeah. Okay.
Yeah.
It's very nice.
Yes, sir. My head does not come in a way.
If it is there.
Yeah. That's a question that we have to sort out during banquet if it is there. Yeah.
How come you're operating in Anantapur from Pune?
Sir, destiny.
Sir,
No,
yes, this to start.
Sir, Belgaum days, sir. Sir, Belgaum.
Oh, Belgaum friend. Okay. Reddy is there. Huh?
Yes, sir.
Okay.
I was supposed to operate from Pune. Then he had some case. So then I thought I will adjust it during our this Alembic Masterclass. And then it's always a fun to be with old Belgaum guys. So, so that's the reason.
Yes, nice.
Yeah. So can you put a? I will tilt the head. No. I will tilt the head. The external camera. No, can you by any means you can show it in center. ये line से अभी now ये line से दिखाओ. Exactly with this line. Because lot things depends on this alloplasty now.
Yes, I think he has to come
Suture,
down.
give me.
The external camera.
Tilt है, no. And then ये light भी adjust कर दो because ये इधर shadow दिख रहा है. Actually नहीं है. There is no.
Yeah,
dip
for
here.
that, do you like to do anything that notch is there? No.
No. There is. That's what I'm saying. So this notch is not there. That's because the light is from this side.
Okay.
Yeah. So this notch is not there, sir.
Fine. But it looks like a notch.
It looks because I will adjust the light. This light also you adjust it from here. Light from this side. So then, yeah, with VTOM you will see there is no notch there. If it is there, I will definitely harvest a conchal cartilage. Yeah, we have to augment that. We have already put a rim graft there.
Oh yeah.
Yes.
The bulbous tip, you would want to do something about that?
So bulbous tip is this bulbous skin there. So you can also see a small light reflux here. Yeah, 1 point light reflux.
Right.
Yeah. So previously, if you see the pre-op photos, you will see that was not there. It was a big nose there. So this is a thick skin, and this is a limitation of our Indian ethnic rhinoplasty.
Okay.
So you have to accept this because of the thick skin. You have to accept this. That's a part about our ethnicity. It's a brown skin.
That's why I call thick-skinned people.
Yeah, that's right.
Hello. Can you put the camera absolutely frontal?
Yeah, maybe
Sorry,
that
sir.
also can help, sir. From the head.
Camera from frontal view. Yeah. Camera इधर से लाओ, trolley लेके जाओ.
Viren,
Sir, what about unilateral alaplasty, sir? On left side, any cell excision?
We'll see. Yeah.
Viren, the other thing, I don't know, I can, again, must be the VTOM or what, but do you think that there is that little bit of anterior septal left-sided?
No. That's a mucosa. Here, no?
Okay, yeah.
This is a mucosa. This is purely excessive mucosa. There was a deviation. I'll just suture it. So,
Okay.
You see, I'll just suture
Yet
it
the
there.
right nostril appears to be little elongated.
Yeah, exactly.
Transversely.
So I will do that alloplasty if required, surely.
Wonderful, Viren. Great.
So, the external, नहीं, इधर से, center से. Give me another one, please, like this. नहीं, आप center से नहीं लाया तो कैसे होगा? Yeah, okay. The light again. Can you adjust the headlight, please? थोड़ा सा पीछे से और थोड़ा नीचे से आ जाओ. So the best thing is for this tissue is just to press and wait. Just press and keep it. So after removal, see how it is. Yeah. नहीं, light थोड़ा ऊपर से लाओ.
Yes, sir. From head and it looks good. Yeah.
No. There is not in center. Yeah.
Maybe he has to come a little bit from down.
Yeah. No. Light.
Head end, but down.
Light थोड़ा कम. अब पहले अच्छा था. बस. Yeah. Focus it. No. Focus the tip. नहीं, light अच्छा है अभी. Focus the tip.
Little bit.
So you can see that it is. It is better now here.
The line
dorsum,
is good.
The mid part is the dorsal aesthetic line is good.
Yes, sir. Yes.
Yeah.
Really good, Dr. Gaisas. Congratulations.
Yeah. So from
Very
this
nice
angle, this
braces.
is looking good. The only worry part is the ala from basal view. Yeah. So we'll see that. And
Sir, can we also have a look at the profile? The profile.
Yeah,
also.
profile from side. The trolley will go there.
Extra पैसा का था.
At profile. Yeah, नहीं, थोड़ा बाहर आ जाओ, मैं ट्रॉली उस साइड लगाता हूँ, and then you come back again.
Conference होके देखो ना, आज में ना बोल रहे.
Yeah. Come from here, come from there. Give me 30 Vicryl. I'll suture that nasal mucosa, and then we'll see. Yeah.
Yes, sir. Yeah.
So I'll just press it one more time. We'll see if that hump is gone.
Infracartilaginous, internal.
Yeah, show me the profile, the side view, the external camera. The external camera, please.
Yes, sir. Yeah.
Yeah.
Excellent.
Yeah. So there is no hump now.
None.
Tip is
So
also
the tip
beautiful.
is big. Yeah. So I will adjust this free dice cartilage here. In case if I feel the dorsum is little low. No, I think it's looking good. The oblique V is also good. Yeah. The
As usual,
oblique V is
amazing,
good.
sir. Yeah.
And if you see the pre-op photos, you see the pre-op photos, see this angle low opening.
Yeah, much
Can you
better.
do the pre-op photos? Pre-op photos, PPT. Yeah.
And now it is like a proper 90 degrees. somewhere.
Yeah. Go side next. Yeah. No. Go back. No, the front. Sorry. Yes.
Yes, sir.
Now you can see that acute angle.
Acute, yeah.
Which has opened up now.
Yeah.
Right?
Very nice.
Very well, sir.
Thank you. So only question is 30 Vicryl. And can you put this VTOM down? ये stand थोड़ा नीचे ले सकते हो क्या? So 30 Vicryl. So just give me 5 minutes, sir. So I will suture this mucosa. Yeah, that VTOM now.
So this you are doing
What I will
under GA,
adjust
is
here.
it? Virender? Under
Yes,
GA
sir.
you are doing. This is
Sir?
under GA or local?
GA. So I will suture this mucosa with CMAP is thinking it's a caudal dislocation or something.
Centering.
Yeah, sorry. No, they are adjusting. हाँ, वो नीचे से ये पूरा निकालो और पूरा नीचे ले लो. हाँ, नीचे ले लो. So because हाँ निकालो और नीचे लगा दो और नीचे लगा दो. हाँ. और थोड़ा नीचे. नहीं जा रहा है? अच्छा लगा दो तो इधर ही लगा. हाँ, सपोर्ट नीचे नहीं है क्या उसके नीचे? I'm just making that stand little down. So leave it. Should I leave it? Yeah. Okay. Just adjust this. I'll just suture the septum till then. Yeah. Because I don't want any confusions, if and buts for this ala. Yeah. Cut it. Yeah. Okay. Let's see. VTOM view, if I can show them. Yeah. Wash, please. Now, for the first time, I have got a good picture.
Yes, sir. It's proper center.
It's proper center. And then there are no, because I'm seeing there is a symmetry, but you was seeing some shadows
Correct,
and
sir.
notches
Yeah, on the
there.
left side, yeah.
Yeah. Is it good, sir? Dr. Vijendra,
Excellent.
sir? Yeah?
Excellent.
Yeah. So there is no notches there. Yeah.
Yeah, correct.
See? I will extend the head again. Yeah.
I don't think you required to do anything else.
Yeah. Right, sir.
Absolutely lovely picture now.
Right. Yeah. Thank you. So
Excellent.
Yeah, in nutshell, what we did was main patient was here for the shortening or the broadness of the nose. So we did from top osteotomy. Then we did a tip plasty. We harvested a septal cartilage, a columnar stud, rim grafts for this narrowing here, and a dorsal onlay graft with a trimming of the skin from down. Right?
Yes, sir. Yeah.
So
and lower lateral underlay.
That's it. And yeah, you are right.
Yeah.
Can you give me a Doyne splint, please? Splint. Udhar ek splint hai. Wo box dena, please. Box kidhar hai wo? Yeah.
Where there are
splint.
times when you do lateral osteotomies, post-operative there will be bleeding and this ecchymosis. How do you prevent that?
Yes, sir. Yes, sir. For that, you have to tell 5 minutes prior to osteotomy to the anesthetist that you are doing osteotomy, so that he will reduce or she will reduce the blood pressure. Then we have to, with this external, you have to take care of the, sorry, give me a xylocaine jelly here. You have to take care of these angular veins by, give me external camera, please. External camera. So this is a 3 mm osteotome. So with this one edge, I will go in. Are you seeing it? Yeah. Idhar se. And I will scratch this periosteum over the nasal bones, so that this angular vein drops in, and there is less injury to the angular vein, and then there is no bleeding.
But it is blind, no? Blind procedure.
Yes, sir, it's a blind process. Sometimes even after doing this, there will be a bleeding.
Yeah. That's
And
what
lastly, the ropivacin with adrenaline, that also will work. But this generally this cutting of that periosteum will take care of this angular vein and the bleeding is less.
And also
And,
the ice pack, no, sir?
also the ice pack. So if the field is good, it's a surgeon infiltration. If there is a bleeding, then it's anesthetist's fault. So no. Jokes apart, excellent surgery, excellent field by the anesthetist here. Yeah. So I'm putting this Doyne splints. I don't pack the nose now.
Hello.
Yeah.
Yes, sir. Yeah.
Yeah. So yeah, lateral alar base resection. The question from the OT is, if I have to do a lateral base resection in this case for making this part more narrow, not for the symmetry, for this narrowing of it. Yeah. So there is the same thing. You have to see the preoperatively the photos. You have to measure the distance between the medial canthus and the lateral canthus. I'll just measure it and show it to you. And the distance between two lobules. So here is the distance. The medial canthus and the lateral canthus is almost 5. It's 5 centimeter. And the distance between medial canthus is exactly 5. Can you see it?
Yes, sir.
5
Yeah.
again. Yeah, it's 5 again. So if I do this alloplasty here, it will look very small nose on a big face. So can you go to PPT again? Sucha. PPT, the first photo. Yeah. See this? See his face, see his cheeks. Right? So if I do alloplasty and narrow his nostrils, it will be very small for his big face.
Yes, sir. Yeah.
Yeah. So, okay. Yeah. Go to the external camera or Doyne splint or the VTOM. So I'll just put a plaster. I've finished my case. So thank you, Rajat and the entire Alembic team. And Dr. Haldipur, Dr. Vijayendra for giving me opportunity to operate since long time in Alembic Masterclass. So thank you, sir. And thank you, moderators. Yeah.
Thank you.
Thank you, sir.
very
Thank you,
much.
sir.
So
As
I
usual, a
once again
pleasure
thank all
watching you.
the Alembic people, in particular Rajit and team. They have done a wonderful job. The audio visual is excellent here, particularly in Bangalore. It is really a feast to watch the whole hall. Everything is very nice, excellent arrangements, and it is not an easy joke to connect in 42 centers.
center. That's
It
right.
is amazing. And first time they had done it, and even the audience was more than 2,500. That is also a big number. And on the great efforts by Rajit and team, I congratulate them. And the show was excellent. And they are sure they'll keep continuing the same thing for the benefit of all our ENT surgeons. And that's the reason why the master class has become one of the most popular ENT live surgical workshop. Thank you all Alembic people. Thank you very much.
Thank you. Thank you, sir.
Thank you so much, Dr. Virendra, for this wonderful live surgery. I'm sure the responses says it all that it was a great learning for all of us. So this was the last surgery for the day. I'm pretty sure the precious knowledge that we have received today will definitely help us in future. Once again, I would like to thank each one of y'all, our faculty members, Dr. Deepak, Dr. Virendra, Dr. Vijendra, Dr. Seema Sheikh, Dr. Janakiram, sorry, and our delegates for the session who have taken out time for their busy schedule and has enlightened us with the knowledge. So thank you, everyone. Have a great day ahead. And lastly, happy Independence Day to all of you all. Bye-bye.
Thank you.
Once again to all of you. Thank you very much.
Viren, if you can still hear me. Are we offline already?
Yes, yes, Simap. Cut it.
I said, make sure you get an invitation for the wedding of his son.
That's right.
Well, have a great evening. Alior Betu.
Thanks. Yes,
Wonderful.
thanks, Simap. Bye. See you soon in Pune. Yeah.
हाँ? ये बंद करो वो? हाँ? हाँ? बंद करो क्या? हाँ? ये लैपटॉप चालू रखना। अच्छा। ये सब निकल गए इसके लिए कि हमेशा बंद हो गया? सब पूरा बंद गया? हाँ तो कर देना बंद फिर। हाँ। ये सबके ये नो सिग्नल आ गए इधर आ गए इधर आ गए। हाँ बंद कर दे। श्योर ना? और ये खोल रहा है फटाफट।